for a hearing on the cost of treating autism, looking at the government's response to the increasing incidence of the disease. Committee is chaired by Congressman Darrell Issa. Ranking member Congressman Elijah Cummings. It's just started.
The Committee on Oversight and Government Reform will come to order. This hearing on 1 in 88 children, a look into the Federal response to rising rates, will come to order. The Oversight Committee exists to secure two fundamental principles. First, Americans have a right to know that the money Washington takes from them is well spent. And second, Americans deserve an efficient, effective government that works for them. Our duty on the Oversight and Government Reform Committee is to protect these rights. Our solemn obligation is to hold government accountable to taxpayers, because taxpayers have a right to know what they get from their government. We will work tirelessly in partnership with citizen watchdogs to deliver the facts to the American people and bring genuine reform to the Federal bureaucracy. This is our mission. And I might say today, in many cases, we're dealing with people who, because of this affliction, may never pay taxes, but in fact, their families and others pay for an entire life. Congress spends a lot of time discussing and debating issues and determining by our philosophical beliefs what the role of government should be. As we have seen in these debates surrounding TARP, stimulus, health care reform, these kinds of issues oftentimes come down to where you fall on an ideological spectrum. Today is no such thing. We're having a hearing focused on something that spans the ideological left to the ideological right. We're drawing attention to something that has no political affiliation, no partisan allegiance, and sometimes, and we believe today, not nearly enough focus on something that does not shorten life, but dramatically or even slightly, but usually more than slightly, reduces the quality of life, both for the individual and for their families. I'm a father. As far as I know, I'm one of the fortunate ones. I'm not the 1 in 88. But right now, if the numbers are accurate, and if they continue to grow from the now 1 in 88 that in some way are ASD affected, we in fact have an epidemic. It could be that some of the 1 in 150 of a century at the start of the previous century was too low, that in fact people were simply not diagnosed. But few people believe that in fact there aren't factors in our society and our behavior, in the air we breathe, the water we consume, or others, that are affecting how many people will be afflicted. We're going to hear from a distinguished panel first of people who do this for a living, try to get to the causes, prevention, I won't say cure today, but at least the treatment, the understanding, and perhaps in some cases truly something that would mitigate their suffering. I know they're frustrated. Congress, although we put nearly $250 million a year directly into research, has not put the kind of dollars, perhaps, that could bring specific outcomes sooner. On our second panel, a number of individuals will say that, in fact, one of the problems is we're looking on one side of the equation and not nearly enough on what to do for the victims of various parts of autism. The fact is, they're all right. There is not enough money being placed on the various possible causes of autism. There is not enough study. Our government does not collect statistics as well as perhaps someday soon we will, so that in fact we can find out what the true number is, cross-check every aspect of how that number, which is a human being, came to be afflicted. The truth is, we have a lot to do. I will not claim that I have come here timely. This is the last few days of my first 2 years as chairman, and this is our first hearing. What I will promise you here today is that we will stay involved in this issue. We will stay involved through staff and through, if appropriate, additional hearings. I also would say to our first distinguished panel that one of the most important priorities I place today is, in fact, that we work with you and help you in this process, that we be a conduit to the rest of Congress on this important issue. In a few moments, I'll be I'll be recognizing by unanimous consent a number of members who would not ordinarily be here at a hearing because they are involved in this issue but serve on other committees. Additionally, I want to apologize to all of those people who rightfully so would be well to be heard here today. I could have had a second panel of at least 20 witnesses from organizations and from affected individuals. We had the difficult job of selecting just 6. And as the ranking member will undoubtedly agree, 6 is already a fairly large single panel. That's one of the reasons I pledge to you today that any organization or individual that in the next 7 days provides to us, as required by our rules, in electronic format, or if you give it to us in paper, we will try to scan it. We will include your statements and your information in the record. We'll hold the record open so that the many who could not be heard live in testimony will, in fact, be at least in the record. I want to particularly recognize Brian Hooker with Focus Autism, the American Academy of Children, and actually it's a long title, who in fact has been one of the people who has championed for today's hearing, and a number of others. They've been essential in my getting a better understanding. I also would like to thank, and we will be recognizing 2 witnesses or 2 members on each side, the former chairman of the full committee, Dan Burton, who years ago began a process of focusing on some aspects of this terrible disease. We, in fact, don't know enough. Our goal is to know more. Today is but a down payment on that. And with that, I'd like to thank the ranking member for his assistance in putting together today's hearing and recognize him for his opening statement.
Thank you very much, Mr. Chairman, and I do thank you for holding today's hearing. Before I get started, I want to pay special note, as you have already done, to our friend who is leaving, Mr. Burton. Over my 17 years on this committee, this has been an issue that he has constantly put forth and constantly made sure that we tried to address as best we could. And so, Mr. Burton, I want to thank you for your vigilance, and I want you to know that although you may be leaving the Congress, as the Chairman has said, we will continue to fight, and I know you will too. Mr. Chairman, we have learned much about autism spectrum disorders over the past decade. Taxpayer-sponsored research has identified risk factors and evaluated therapies to assist with some symptoms. Physicians and parents now have a better understanding of the developmental signs and the symptoms, allowing for earlier detection. And educators have experience with new methods and approaches for assisting children with autism. Congress has also acted to help individuals with autism and their families in significant ways. In 2010, we passed the Affordable Care Act, which contains significant new protections. Insurers may no longer discriminate against individuals based on pre-existing conditions. Insurers may no longer impose lifetime caps on health care coverage. New plans must include screening for autism without additional costs to the parents. And young people diagnosed with autism spectrum disorders may remain on their parents' health insurance plans until they are 26 years old. These are real and significant protections that will improve the lives of millions of American families. Even with this progress, there is still more to learn, and there is still more to do. While autism affects all racial, socioeconomic, and ethnic groups, some studies have shown that African American, Hispanic, and Asian children are less likely to receive an early diagnosis. These delayed diagnoses cause minority children to be further behind in the development of language and motor skills. We must be vigilant in emphasizing early detection and intervention for all our children, as an early diagnosis can make a critical difference in the lifelong development of a child. We must also continue to invest federal research dollars in new and evolving therapies to improve the lives of those with autism spectrum disorders. In my district, we house the Kennedy Krieger Institute, an internationally recognized institution dedicated to improving the lives of individuals with developmental disorders. These institutions improve the quality of life, education, and continued development of those affected by autism spectrum disorders, and we must continue to support them. Today's hearing is an opportunity to examine what has been done about autism spectrum disorders to date and what more needs to be done in the future. There are many experts, individuals, and groups who can help us in this effort. And I want to take this moment to thank all of you for being here. As the chairman said, there's so many people who are interested in this issue, so many who wanted to speak. But I want to say to you what I said to Bob Wright of Autism Speaks a little earlier today. I thank you for caring about somebody other than your children and yourselves, because what you are doing here today is raising this issue so that other children, other than those, or other folks, other than those who may be in your own families, maybe your friends, will benefit in the future. In other words, you are touching the future, and you are making it possible for those who are going through the autism spectrum disorders to have a better future. And so I thank you all for what you're doing. And as I said to Bob Wright, you must stay the course. One of the things that I've learned from being in Congress these 17 years is that in order for these causes to move forward, you have to keep banging the drum. And you must keep banging it louder and louder and presenting your case so that after it's all over, there's not, as my mother would say, motion, commotion, emotion, and no results. I want you to be successful in what you're doing. Life is short. And so what we must do is try to use our energy so that we can get the best possible results. And I am so glad the chairman said what he said about sticking with this, addressing it, and we encourage all of you to work with us as we move forward. And with that, Mr. Chairman, I thank you.
I thank the gentleman. We now recognize the former chairman of the full committee, Mr. Burton, for 5 minutes.
Thank you, Mr. Chairman. Let me start off by saying that, contrary to what has been stated in the media over the years, I am not against vaccinations. I believe that vaccinations have a very important place in our society and have given us one of the best health regimens in the history of mankind. People live longer and live better and have less disease because we have vaccinations. What we have always opposed is putting toxic chemicals or metals in the vaccinations. Thimerosal contains mercury. When I was a boy, we used to have mercury in thermometers. And they said if you break that thermometer and the mercury gets on your hands as years went by, that was toxic. In Indianapolis, we had a school where in the chemical laboratory or in the health science room, they broke a vial that had some thimerosal in it. They evacuated the school. They burned the clothes of kids that came in contact with it, and the fire department came in with all kinds of equipment to make sure they weren't exposed to it. Women who are pregnant, they say don't eat fish that has mercury in it. And they caution them that there's certain kinds of fish you don't eat. You don't drink water that has any mercury in it. There's all kinds of reasons not to be exposed to mercury, and yet we continue to put it in vaccinations as a preservative. In 1929, they came up with thimerosal. They tested it on 29 people that had meningitis. They all died of meningitis, but they said the mercury in the vaccinations or the thimerosal didn't cause any of the problem. It was not a contributing factor. So ever since 1929, it has never been completely tested, and they continue to use it in vaccinations. It wasn't so bad when a child got one vaccination or two or three, but when they get as many as 28 or 29 before they go in the first grade, it really hurts them. it causes a cumulative effect. The brain tissues do not chelate it. It stays in there, and it causes severe, severe problems. Now, I had, during the chairmanship, which I had in this committee when I was chair, for 6 years, we had about 4 years of hearings. We had people from all over the world, scientists from every part of the world, doctors from every part of the United States who testified. And people from CDC and FDA said there's no evidence that the thimerosal causes any neurological problems in people who are vaccinated. And then we kept on and kept on, and finally we had some people from FDA and CDC who came and testified and said there is no, get this word, there is no conclusive evidence that the mercury in the vaccinations causes neurological disorders. No conclusive evidence. Now, that word conclusive ought to stick in everybody's minds, because what it means is there's a possibility. And my question has always been, and I'm convinced that the mercury in vaccinations is a contributing factor to neurological diseases such as autism and Alzheimer's. I'm convinced of it after all those years we had hearings. But that word conclusive, there's no conclusive evidence, creates a doubt. And my question to the presidents and CEOs of pharmaceutical companies has always been, if there's any doubt that the mercury in vaccinations can cause a neurological problem, then get it out. You shouldn't put mercury in any form in the human body, especially in children in vaccinations, or adults, in my opinion. When we get a vaccination for flu, every year we get a flu vaccination, we have thimerosal, fellas. I don't know if you know that or not. They're injecting a certain amount of mercury in their bodies. And over a period of time, I believe it does have an adverse impact on the neurological system of adults. I think it's a contributing factor to other diseases, such as Alzheimer's. But let me just say that the thing we need to do is always err on the side of safety. If the pharmaceutical industry were to go to single-shot vials, then you would eliminate the possibility of neurological problems from vaccinations, because there wouldn't be any mercury in it. And the last thing I want to say real quickly, I've got 27 seconds, is we passed the Vaccine Injury Compensation Fund to compensate those people who were injured by vaccinations. And it was supposed to be something that people could work with the government to get that money. The pharmaceutical companies were putting money into that fund. But it's so hard for a person who's had a damaged child or a damaged adult to get any money out of that fund. It's unbelievable. And we need to reevaluate that fund to make sure people who are damaged by mercury and vaccinations need to have access to that, so they can at least have some compensation to help with the rest of their lives. These people are going to live 60, 70 years, and they're going to be a burden not only on the families, but on society itself.
I thank the gentleman. The gentleman yields back. I now ask unanimous consent that our colleagues, Mr. Posey of Florida, Mr. Barrow of Georgia, and Mr. Matheson of Utah be allowed to sit on the dais and ask questions at the conclusion of other seated members. Without objection, so ordered. It's now my pleasure to recognize the distinguished gentleman from Illinois, Mr. Davis, for 5 minutes.
Thank you, Mr. Chairman, and I thank you for calling this hearing. As one who has spent much of my adult life working as a professional in the areas of health planning, health research, and delivery, I firmly believe that the federal government has an important role to help understand autism spectrum disorders and to address the needs of our citizens with autism across their lifespans. I, too, want to commend the former chairman of this committee, my good friend Dan Burton, for using his position as chairman and beyond to focus on this particular issue and cause the committee and others to continuously take a hard look at it. Dan, I commend you for your efforts and certainly wish you well as you revert back to private life. I'm very proud to represent a premier institution involved in the research and service provision of people with autism. Specifically, the Therapeutic School and Center for Autism Research, operated by the Easter Seals in my congressional district as a part of the Illinois Medical District, which is the largest medical district in the country. This one-of-a-kind facility is unique in the nation because it combines on a single campus educational, research, training, early intervention, school-to-work transition, and independent living capabilities. The continuum of services for persons with autism is impressive and will help advance a research-driven context for teaching, learning, and clinical and medical interventions related to autism. As an ardent advocate of persons with all types of disabilities, physical, mental, or developmental, I strongly supported the provisions of the Patient Protection and Affordable Care Act that protect families and individuals affected by autism spectrum disorders. I want to thank all of the witnesses for coming to join with us. Again, Mr. Chairman, I thank you for calling this hearing and look forward to our discussion here this afternoon, and I yield back the balance.
And if the gentleman would yield his remaining time to the gentleman from Ohio, I'd appreciate it.
I would be delighted to do so.
Mr. Kucinich is recognized for 2 minutes.
Thank you very much, Mr. Chairman. Having had the opportunity to work with Mr. Burton on this for the last 10 years, I remember well, as I'm sure Mr. Burton does and some members of this committee do, a time when a provision was snuck into a bill on Homeland Security that essentially shielded from lawsuits the manufacturers of thimerosal. This was 10 years ago. And you know what? No one, for the members that have been here less than 10 years, no one knew where that provision came from. It came out of nowhere, and it ended up getting buried in a conference report, and of course it passed. And, you know, I mention this because it's not as though we just discovered this matter, and while I salute the Chair for holding this hearing, we didn't just discover this. And my own theory is, well, there's studies that are out there that are implicating environmental factors in autism. Think about this for a minute. We know, as Mr. Burton laid out, the component of thimerosal, one of the components supposedly to stabilize it, is mercury. Well, we all know that mercury is more than a contaminant. It's an environmental toxin. But it doesn't only exist in liquid form. It's, you know, mercury can also be inhaled. And I would guess, and this is just my theory, that we're not only talking about drug manufacturers, we might be talking about coal companies too. You know, we have to be aware. There are reasons why this Congress and this government has not effectively addressed this issue. And when you had Lilly and others, Eli Lilly and others, contributing millions of dollars to try to affect the outcome of elections, you know, I will tell you, well, I salute this Chair for taking this on, because at the bottom of this, you have special interest groups who would resist any deeper research on it because it's going to affect their bottom line. Meanwhile, you have children all over the country turning up with autism. So this is a new beginning. I salute the Chair for making it, but this goes way beyond thimerosal, and you could start thinking about coal. Thank you.
I thank the gentleman on all sides. I now ask unanimous consent that our colleague from New Jersey, Mr. Smith, be allowed to participate in today's hearing. Without objection, so ordered, and I will announce that if any individuals would like to be in a little more comfortable situation, we do have an overflow room, and if they would just let our staff know, they'd make sure that if they gave up their seat here, that they would be able to be in the overflow room. It may be more comfortable for some of our guests. I now turn to our first panel. Distinguished Dr. Alan Guttmacher is Director of the Eunice Shriver National Institute of Child Health and Human Development at the National Institutes of Health. And I actually knew the namesake of your organization during her time. And Dr. Colleen Boyle is Director of the National Center of Birth Defects and Developmental Disabilities at the CDC. And with that, pursuant to the requirements and rules of this committee, would you please rise to take the oath? And raise your right hands. Do you both solemnly swear or affirm that the testimony you are about to give will be the truth, the whole truth, and nothing but the truth? Thanks. Please be seated and let the record indicate both witnesses answered in the affirmative. You are important witnesses, and we will not stop you if you go slightly over 5 minutes. But we do have a large second panel, and I would ask that you bear in mind that all of your opening statements and additional extraneous material you may choose to submit to us will be placed in the record. So if you abbreviate or go off message, it doesn't change the official record for you. And with that, Dr. Guttmacher, you're recognized.
Thank you, Mr. Chairman. I'm also a pediatrician and medical geneticist and a member of the Interagency Autism Coordinating Committee, or IACC, reauthorized most recently by the Combating Autism Reauthorization Act of 2011. Let me thank the Congress for its continued support of research and other activities regarding autism spectrum disorders. That support has made possible remarkable advances in autism research and helped to better identify and meet the needs of people with ASD and their families. ASD includes diverse conditions that share distinctive styles of or impairments in communication skills and social interactions, as well as restricted, repetitive, or stereotyped behaviors. The combination and degree of impairments vary, creating an array of conditions that range from what many would see as normal to significantly disabling. 2 decades ago, ASD was thought rare. Today, with CDC's latest prevalence estimates, it is a national health priority. The IACC plays a pivotal role in bringing together federal agencies, nonprofit organizations, and the public to identify priorities and strategies to address them. It includes individuals on the autism spectrum, parents of children and adults with ASD, other advocates, researchers and service providers, and officials from federal agencies. The IACC welcomes public comment at all full committee meetings, regularly invites written public comment, and holds town halls. Thus, a diversity of perspectives on ASD informs IACC activities and recommendations. It is a committed group. While the law requires 2 meetings a year, the committee and its subcommittees meet as many as 17 times a year. The law charges the IACC to update a strategic plan annually. We are drafting, as always, with autism community input, a 2012 update that reflects the latest advances, remaining gaps, and emerging needs in autism research. The plan encompasses priorities from fundamental biology to services across the lifespan. Over the past decade, autism research funding has grown substantially. The NIH leads federal research efforts on ASD, investing $169 million in fiscal year 2011, 3 times more than 10 years ago. In 2009 and 2010, $122 million in additional American Recovery and Reinvestment Act funds were also invested. As Congress has emphasized, early diagnosis and intervention are critical. This year, NIH-funded researchers identified brain pattern aberrations at as early as 6 months of age in infants who went on to develop autism, the earliest such changes ever recorded in autism, and one of a number of recent findings to suggest that the factors causing autism may operate very early in development. Last year, researchers demonstrated that doctors' offices can use a short questionnaire to screen inexpensively for ASD at the 1-year well-child visit. Another promising diagnostic tool, a 1-minute test that detects eye gaze patterns specific to autism, had nearly 100% specificity in infants as young as 14 months. But early diagnosis is valuable only if effective interventions are available. Recent ASD trials have validated early interventions to improve health outcomes and quality of life. For instance, a recent behavioral intervention study showed improved IQ, language, and social development in young children. And progress is also being made on interventions for adults. A recent study showed, for instance, that for the many adults with ASD who have impaired ability to recognize faces, a computerized training program improved facial recognition skills. Many recent advances have come from NIH's Autism Centers of Excellence program, which currently supports 9 centers and networks across the country, with 2 additional awards expected in 2013. The research covers a variety of topics aligned with the IACC strategic plan, including nonverbal ASD, genetic and environmental risk factors, potential treatments, and determining why ASD is 5 times more common among boys. We do not know the causes of ASD, but recent findings highlight the need to focus on both environment and genetics. NIH and CDC have established large research networks to collect extensive data on environmental exposures and health outcomes and conduct powerful analyses to identify factors that contribute to autism. Those networks explore possible causative factors in the environment before, during, and after pregnancy. Just this week, one of these networks published a study that suggests prenatal and early life exposure to car emissions is associated with autism. On the services front, HRSA has invested substantially in improving physical and behavioral health of people with ASD, practitioner training, and service provision. In fiscal year 2012, Congress appropriated over $47 million to HRSA for autism and other developmental disorders. This supports 43 interdisciplinary training programs which provide services and training to 41 states and include autism intervention projects for underserved populations. Federal agencies also use public-private partnerships to maximize our work, such as NIH's National Database for Autism Research, which coordinates with other autism data repositories to enhance researchers' access to data. Programs like these that involve collaboration with patients and families bring together hundreds of researchers and clinicians with tens of thousands of people nationwide affected by ASD. The Administration on Intellectual and Developmental Disabilities, with help from several nonprofit organizations, supports the Autism Now project, offering a call center, a web-based clearinghouse of resources, and twice-weekly autism webinars. The NIH-supported Association of University Centers on Disabilities is improving early identification of autism through 25 Act Early ambassadors who train physicians in identifying, diagnosing, and managing ASD. In conclusion, since the establishment of the IACC, a wide variety of research, service, and education expertise have come to bear on autism. Research is rapidly translating to practical tools for youth in the clinic and the community. Federal agencies are coordinating efforts to identify best practices to support the lifelong education, health, and employment needs of people on the spectrum. Thank you for this opportunity to provide testimony on such an important topic.
Thank you, Doctor. Dr. Boyle.
Good afternoon, Chairman Issa, Ranking Member Cummings, and distinguished members of the committee. Thank you for the opportunity to be here today. I'm Dr. Colleen Boyle. I'm an epidemiologist and the director of the National Center on Birth Defects and Developmental Disabilities at the Centers for Disease Control and Prevention. CDC works to keep America safe from health threats of all kinds. Our FY 2012 autism budget is about $21 million, and today I'm going to describe how we use those funds. Autism spectrum disorder, or ASD, is an important public health concern in the United States. ASD is a group of developmental disorders characterized by unusual patterns in communication, behavior, and attention. While there's no known cure, research is yielding innovative screening tools to detect ASD in early childhood and new behavioral therapies that can improve outcomes. CDC data indicate that more children are being identified with an ASD than previous years. The toll of ASD is significant and has profound implications for affected children and their families. CDC works steadfastly to alleviate this burden by tracking ASD, promoting the early identification, and addressing the unanswered questions through research. CDC supports ASD surveillance or tracking in 12 states: Utah, Colorado, Arizona, Missouri, Wisconsin, North Carolina, New Jersey, Maryland, South Carolina, Arkansas, Alabama, and Georgia through our Autism and Developmental Disabilities, or ADAM network. ADAM's goal is to provide comparable population-based prevalence estimates in different sites over time. In March of this year, CDC released updated estimates of the prevalence from the ADAM network based on our 2008 data, indicating that 1 in 88 children had been identified with an ASD. This is greater than the prevalence of 1 in 110 released in 2009, based on 2006 data, and 1 in 150 released in 2007, based on 2002 data. While there's no simple explanation for the increase, we know that it is due, at least in part, to improved diagnosis and increased recognition. Data from the ATOM network provide more than just a prevalence estimate. And because of this data, we know that ASD remains nearly 5 times more common among boys than girls. We know that the largest increase over time are among Hispanic and African American children and children without intellectual disability. We know that the prevalence varies widely. The identified prevalence varies widely from 1 in 210 to 1 in 147. And that although more children are being diagnosed at earlier ages, there are far too many that are not diagnosed until it's too late to receive the full benefit of early services. Overall, it's clear that families and children need help, and our data is helping to provide that. Research tells us that the earlier a child is connected to services, the greater the benefit. CDC works to increase early identification by offering free tools and assistance to states through our Learn the Signs Act Early program. We provide these tools to healthcare professionals, child care providers, and parents with a focus on minority and economically disadvantaged populations. CDC is also working with our federal partners to provide national goals in early screening, diagnosis, and service enrollment, giving communities as well as the federal government a benchmark to measure progress. To identify causes of ASD, we must first understand the risk factors. CDC's study to explore early development is the largest epidemiologic study of ASD in the country, and it involves sites in Georgia, North Carolina, Massachusetts, Iowa, California, and Pennsylvania. CDC works to identify factors that put children at risk, including genetic, environmental, maternal health, and behavioral factors, with a special emphasis on the interaction between environment and genetic factors. We are an active member in the Autism Coordinating Committee, and we really provide that epidemiologic and public health perspective. CDC contributed to the development of the IACC Strategic Plan for Autism Research, and our activities are key components of that plan. ASD is an important and an immediate public health concern. More children than ever are being identified, and families and communities are struggling with the financial burdens, the complex health care decisions, and the service needs. We know it is frustrating to have more questions than answers, and we share that frustration and are committed to improving our understanding of what is putting our children at risk. CDC will continue to document the burden of ASD in states through our ATOM network, develop resources, and help states improve early identification through our Learn the Science Act Early program, and maintain our important epidemiologic focus through the SEED research network to understand why some children are more likely to develop autism. Thank you for the opportunity to present this testimony, and I'd be happy to answer questions.
Thank you both. I'm going to recognize myself first, and I'll ask both the experts to forgive me for being very basic in a couple of questions, but I hope that it sheds a balance on this hearing. Dr. Boyle, as far as you know, for either of you, does autism in history predate all vaccines? In other words, was there autism before there were vaccines?
I would turn to my colleague, my physician colleague, but I would say definitely.
Doctor?
So autism was the first not described until 1943 by a constituent, actually, of Mr. Cummings, Leo Conner, who was a child psychiatrist at Johns Hopkins, who first noticed 11 individuals with similar patterns of behaviors that he described and coined the term autism to describe.
But were those likely or documentably things we can look back into history. And I want you to say with certainty or with likelihood, because I think it's important for all the people who are dealing with this affliction.
Absolutely. I know that Dr. Connor's view, and I think others, is that this probably existed before, just no one had noticed the pattern. There's certainly descriptions of individuals from well before the immunization era who would have what we would take today to be autism spectrum type disorder. It's not well documented before that. I think there's heavy suspicion that it existed before vaccination.
Okay, now I'm going to follow up with that. Is it fair to say that today the state of science, and I think Dr. Boyle said this very well, is that autism of various types has multiple causes in each of your opinions?
Absolutely, and they have both a genetic, biological basis and also an environmental basis.
So, again, I'm trying to be very basic, and I apologize, but I think for all of us as we go through this, it's important to sort of build on something. So it's fair to say that autism, like cancer or like other diseases often, is a group of afflictions, meaning that although the characteristics may be similar, in fact, there are multiple causes and thus likely multiple treatments and or multiple forms of prevention.
I think it's not only fair to say, but I think as simple as that question may be, it's the most important question in some ways to ask, because it explains some of the challenge in trying to figure out autism, but also points the direction to do it. Until we can better understand the biological bases of these different forms of autism, it will make it difficult to understand any of them.
I want to ask each of you one of the toughest questions, and I inherit this series of hearings, but I want to inherit them new. Is it fair to say that we can rule nothing out in absolute terms from being a contributor? You heard the gentleman from Ohio talk in terms of mercury coming in air form. Obviously, the former chairman spoke of the possibility of vaccines having a direct relationship. Is it fair to say that these multiple causes that we suspect, the fact is we can rule nothing out, including, and I'm not stating as a fact, I really am stating as a question, including things we haven't yet looked at? Is that possible, that there's yet more causes that will be viewed and nothing can be ruled out?
It's certainly true that those things we haven't looked at yet we can't rule out for sure. I think that there have been some things looked at very heavily that, while it's always difficult in science to rule anything out as a possibility for occasional individuals, I think there's sort of gradations of suspicion, and there's some various kinds of possible factors been looked at so carefully that we can rule them out as being involved in the vast majority of individuals.
I'm going to ask one last question, and then I'm really feeling like this is so far above my head that as I continue to study and work with people, I'll learn more. But one of them that wasn't mentioned in either of your opening statements, but I believe is now under suspicion, is the age of parenting. Would either of you feel comfortable talking in terms of we as a society are waiting till later, both on the male and female side, to have children, and science is cooperating with us? Do you believe that that is an area that needs further study?
It does need further study. There is certainly some evidence to suggest that paternal age particularly does have some correlation with the rate of autism. It's clear, though, that that's not a factor acting alone. Many older fathers have children who do not have any form of autism. Many younger fathers have children who do have quite frank autism. So it's in any given situation, it's not the factor, but does, in a public health sense, does it play a role? It does.
Thank you. And I apologize I didn't have time to ask any questions related to what to do with people once they are afflicted. And quite frankly, I don't think I've done enough justice to the fact that there are so many interest groups, each of which is fragmented into components that I didn't even mention here today. But I thank the ranking member and would recognize him here for his questions.
Thank you very much, Mr. Chairman. Just kind of following up on what the Chairman just asked, in talking to folks behind you, there seems to be a frustration. I see everybody's, I wish you could see them behind you. They're shaking their heads. There's frustration.
Well, no, yes, at any time.
With regard to coordination of efforts with regard to, research. And I guess what I hinted in my opening statement that I want us to try to move towards trying to make a difference. And I know that's why the chairman feels too. We don't know how long we're going to be sitting on these panels and in the Congress, but we want to use our time effectively and efficiently. And what can we do to help the folks behind you get to the coordination, the kind of things that they're looking for to have an impact? Because they are thoroughly frustrated. So, I mean, can you help me with that? Can you help us?
Yeah, I think we can also share your frustration. I think all of us are frustrated at the rate of progress in terms of really understanding autism, having interventions to make a difference. So we clearly share that frustration. Perhaps because we're involved in it, we have obviously a different perspective on the frustration, but we not only understand that others have it, but do share it. I think in terms of what the Congress can do, I think some of you've already done, clearly in terms of funding for this area, but also I think in terms of the role of the Interagency Autism Coordinating Committee, and specifically the area you've mentioned is the frustration, that is coordination. I think the IACC has done a very good job in its relatively few years of existence, in fact, in coordinating both work among federal agencies, but also coordinating the federal agencies and the advocacy organizations, individuals, and others to really try to come up with really community viewpoints about what should the priorities be within research, what should the priorities be in terms of service delivery, invention, et cetera. So that I think that while there's always room for better coordination, I think the coordination among agencies is much better than it was a number of years ago. And in fact, across other areas of scientific research.
But you're also saying we can do better.
I think we can do better, but I think we are doing a lot better, and I would point to this as actually one of the areas in science where there is particularly good coordination at this point in time. Good enough, no, but particularly good, yes.
Let me ask this. Major federal efforts to confront significant health crises have been mounted in the past. Breast cancer, Alzheimer's, and AIDS have all been the focus of major efforts. How do you think the federal effort to confront autism spectrum disorders compares to those other federal efforts?
Well, certainly, scientifically, they each present their own challenges and their own opportunities, but different kinds of challenges. One of the particular ones the Chairman already referred to in terms of the diversity of conditions are all lumping as one here. So I think that presents its own challenges. It also presents some particular coordination challenges as well. I think it's hard to compare, one sort of disease movement versus another. They need to all, I think, be crafted with acknowledgement of the particular qualities of the disease or diseases that you're trying to approach.
Let me ask you, yes, Dr. Boyle.
I was going to say that, autism, like breast cancer, is a very complex issue. And although it may not seem that, with federal dollars, we've made considerable investment in research and programs and tracking. So, and we're just starting to see some of the benefit from that. We're starting to see some of the research come out. And there really is an explosion of information. A lot more to be done, particularly on the environmental perspective. A lot more focus has been on the genetics, and I think, and that's been a discussion at the IACC level. We need to be moving more into the non-genetic related aspects.
Let me ask you this. The Interagency Autism Coordinating Committee is the tip of the spear in the federal efforts to strategically address autism. Is the committee's ability to accomplish its mission hampered by the absence of adequate representation from both private and nonprofit sector? And would the coordinating committee be better positioned outside of NIH, since treatment and services are important elements in the mission of the committee? And then you can answer that and I'm finished.
The newly reauthorized committee is larger than its predecessor, and I think that has been an advantage to the committee. It has more membership. I think like any committee, it struggles with, if you were to craft what's the perfect membership of the committee, you struggle with wanting clearly to be inclusive, and at the same time making the committee effective in terms of size, et cetera. I think that the committee tries to make sure about the inclusion by, in fact, inviting public comment at its meetings, having town halls, other kinds of things, so that even those not represented directly on the committee have a voice in the room.
I would agree with that, too.
I thank the gentleman. I now ask unanimous consent that the distinguished gentleman from Virginia, Mr. Moran, be allowed to sit in this hearing without objection. So ordered. I now would also ask unanimous consent that Mr. Burton has waived 2 minutes of his 5 minutes so that he can show a video before he begins. So if the video can be shown, and then the gentleman will have 3 minutes afterwards.
Thank you, Mr. Chairman. Let me preface my remarks by saying I know there's many causes of autism, but the one we're talking about today, as far as I'm concerned, is the mercury in vaccinations and in the environment. And the University of Calgary in Canada has done this research, and I want everybody in the room, and particularly my colleagues, to see what the research shows.
How mercury causes brain neuron degeneration. Mercury has long been known to be a potent neurotoxic substance, whether it is inhaled or consumed in the diet as a food contaminant. Over the past 15 years, medical research laboratories have established that dental amalgam tooth fillings are a major contributor to mercury body burden. In 1997, a team of research scientists demonstrated that mercury vapor inhalation by animals produced a molecular lesion in brain protein metabolism, which was similar to a lesion seen in 80% of Alzheimer's diseased brains. Recently completed experiments by scientists at the University of Calgary's Faculty of Medicine now reveal, with direct visual evidence from brain neuron tissue cultures, how mercury ions actually alter the cell membrane structure of developing neurons. To better understand mercury's effect on the brain, let us first illustrate what brain neurons look like and how they grow. In this animation, we see 3 brain neurons growing in a tissue culture, each with a central cell body and numerous neurite processes. At the end of each neurite is a growth cone where structural proteins are assembled to form the cell membrane. 2 principal proteins involved in growth cone function are actin, which is responsible for the pulsating motion seen here, and tubulin, a major structural component of the neurite membrane. During normal cell growth, tubulin molecules link together end-to-end to form microtubules, which surround neurofibrils, another structural protein component of the neuronal axon. Shown here is the neurite of a live neuron isolated from snail brain tissue, displaying linear growth due to growth cone activity. It is important to note that growth cones in all animal species, ranging from snails to humans, have identical structural and behavioral characteristics and use proteins of virtually identical composition. In this experiment, neurons also isolated from snail brain tissue were grown in culture for several days, after which very low concentrations of mercury were added to the culture medium for 20 minutes. Over the next 30 minutes, the neurite membrane underwent rapid degeneration, leaving behind the denuded neurofibrils seen here. In contrast, other heavy metals added at this same concentration, such as aluminum, lead, cadmium, and manganese, did not produce this effect. To understand how mercury causes this degeneration, let us return to our illustration. As mentioned before, tubulin proteins link together during normal cell growth to form the microtubules which support the neurite structure. When mercury ions are introduced into the culture medium, they infiltrate the cell and bind themselves to newly synthesized tubulin molecules. More specifically, the mercury ions attach themselves to the binding site reserved for guanosine triphosphate, or GTP, on the beta subunit of the affected tubulin molecules. Since bound GTP normally provides the energy which allows tubulin molecules to attach to one another, mercury ions bound to these sites prevent tubulin proteins from linking together. Consequently, the neurite's microtubules begin to disassemble into free tubulin molecules, leaving the neurite stripped of its supporting structure. Ultimately, both the developing neurite and its growth cone collapse, and some denuded neurofibrils form aggregates or tangles, as depicted here. Shown here is a neurite growth cone stained specifically for tubulin and actin, before and after mercury exposure. Note that the mercury has caused disintegration of tubulin microtubule structure. These new findings reveal important visual evidence as to how mercury causes neurodegeneration. More importantly, this study provides the first direct evidence that low-level mercury exposure is indeed a precipitating factor that can initiate this neurodegenerative process within the brain.
Thank you very much, Mr. Chairman. You know, there's an old saying, one picture's worth 1,000 words. I have read, I don't know how many studies on this whole issue. And I think I've had some of you doctors before. I think, Dr. Boyle, you've been before our committee before when I was chairman. And I have great respect for you and for the FDA and HHS. I think you do a great job. But sometimes I think maybe outside influences have too great an impact on the scientific research that's necessary to find cures for major problems. Now, we've gone from 1 in 10,000 children known to be autistic to 1 in 88. It is worse than an epidemic. It is an absolute disaster. And how anybody can look at that study and see the actual brain cells deteriorating when put next to a very small, minute amount of mercury, it mystifies me. How can anybody at the CDC and the FDA watch something like that and say that the mercury does not have an impact on neurological problems? Now, granted, it may be from other things besides vaccinations, but vaccinations that contain mercury should not, under any circumstances, be injected into any human being, especially children who have a very fragile immune system. And children get as many as 28 or 30 shots before they go to the first grade. My grandson got 9 shots in 1 day, and it turned him into a horrible situation that banging his head against the wall, couldn't go to the bathroom, all kinds of things. And these people will tell you all about that. And so all I would pray to you, beg you to go back to FDA and HHS and say, come on, let's get with it. There may be other causes, but let's get mercury out of all vaccinations, which is a contributing factor. If you do that, and you can go to single-shot vials that cost, what, a penny, 2 cents a piece, it won't hurt anything. And I don't mind if the pharmaceutical companies get legislation passed here that protects them from class action lawsuits, as long as they help the Vaccine Injury Compensation Fund and get mercury out of these vaccinations. Please, I'm leaving. I'm not going to be here anymore. You won't have to watch me up here anymore. But please go back and work on it, will you? Thank you.
I thank the gentleman. We now recognize the gentlelady from the We now recognize the gentlelady from the District of Columbia, Ms. Norton.
Thank you, Mr. Chairman. Actually, I would have liked to have heard the response given how, but I don't want to take it from my time.
No, it's, I apologize. The gentlelady is right. Did either of you had a response? I realize there was not an embedded question necessarily there, but if either of you want to make a comment on the video, if you're familiar with it, it will be in part of the record. You can do it afterwards, but if you had a comment now, we'd certainly welcome it.
Well, I'd be happy to make a comment about the vaccines themselves. So since 2001, thimerosal has been removed from all vaccines given to children, with the exception of the multiple.
Please, you know, we said that the record will remain open for all comments, including ones you may want to make as a result of this. So you will have an opportunity to voice yourself completely. Please, Dr. Boyle.
I'm going to say with the exception of the multi-vial flu vaccine.
Thank you. The gentlelady may begin.
Thank you, Mr. Chairman. I have a couple of questions. It really has to do with just who we're talking about. It would probably be the case that many of these children who may have some features of autism were not recognized early, and you indicated how difficult it is to backtrack and do something about it. So I assume that there are millions of people walking around, or not. Now, where we do recognize what is seen as a disability, the IDEA says there must be services provided in school and the rest now. So a child might be able to get, I don't know, all manner of services. Services relating to speech and to movement, very primary services. Then this person graduates out of school where there is no IDEA. What does, so I have to assume that there must be parents and relatives with such children who were not recognized, for whom nothing was done. What are we doing about these young people or older who have not had any services? Do they have anything like IDEA available to them? Any services that they automatically qualify for? If not, what do we do with them?
Well, I mean, I think that's a real challenge. This topic about understanding transition from childhood to adult and sort of the services associated, the benefits, the impact of autism across the lifespan is a really important.
No, but my question goes to what do we do to the child who is no longer a child, 18 or 19? The mother and father have done all they could. This is an adult child. These may be aging parents. What does that young person do? Dr. Guttmacher?
Well, I think, Congresswoman, it's clearly a real challenge for our society. And as you well know, your historic interest and support for the Down Syndrome Caucus, many of the issues you're bringing up here as applied to autism are extremely similar, if not identical, to those for children who become adults with any kind of disability or
except that we could recognize Down syndrome.
Exactly. So there is clearly an advantage of having been diagnosed earlier in life and getting services.
What are we doing with these young people, doctor?
Well, we're doing, I think the first thing we're trying to do is to diagnose more effectively early.
No, I want to know today, you have such a person, they weren't diagnosed effectively, is 21 years old. What do I as a parent do with this young person?
Well, the first question is, even if it's recognized at the age of 21, often individuals who we would now describe as being on the ASD spectrum are simply seen in their families having particular character traits or whatever and are never, quote unquote, diagnosed. I think the question for any of these, for parents of young adults and for the young adults themselves, is trying to find the best fit in society in terms of employment, et cetera.
Thank you, doctor. I have one more question, and my time is running out. In other words, there's nothing that we're doing to them. It looks like we don't have any mandated services for them, and that it falls back. The Affordable Health Care Act may help to provide some medical services, but this is tragic if we have not found, not a bridge, but a way to accommodate an adult who may still become a functioning member in some way in society. But this is the question before my time runs out. I've often noticed that parents of highly educated people come forward and speak up for Down syndrome, so middle-class parents. Why is that? Is there a difference in who recognizes? Is there a difference in who gets it, an ethnic difference, a class difference in who gets or recognizes this disease or this condition? Or is it an across-the-board condition?
It's an across-the-board condition. There clearly are issues, again, because it's not always diagnosed. Those who have greater access to higher quality medical care, since it's usually a medical diagnosis that's made, tend to have the diagnosis made more frequently. So those who, for various reasons of barriers to access, are less likely to have the diagnosis.
What is the minimum age that we should be looking to if we have a child to see whether autism is perhaps there?
As I mentioned in my testimony, there is now a checklist and approach that's being used right around 1 year of age in the hope to make the diagnosis at that point, and we hope eventually even younger. The younger we can make it, the better.
Thank you, Mr. Chairman.
Thank you. Dr. Boyle, I think you had an additional statement.
Well, a couple points on that last one. So we do have tools to help parents identify children as early as possible. Those are free. They're on our website. And the most important thing that parents...
They know it. The mother knows it. The father knows it. It's what is available.
We have information about what to do with it, how to have a conversation with your physician. So really guiding parents with that.
Thank you, Mr. Chairman. In other words, it's up to the family to try to figure it out.
I thank the gentlelady, and thank God that there are families who care so much, and that is always a big part of it. With that, we go to our first doctor on the panel, Dr. Gosar, for 5 minutes.
Thank you, Mr. Chairman. First of all, I'd like to acknowledge my colleague, Mr. Burton, for making this, instrumental in representing so many people out there. One of the things I wanted to ask Dr. Boyle in your testimony is I didn't hear a prevalence about diet.
Excuse me, could you
I didn't hear a pertinent aspect of focusing on diet.
Diet. So we do, within the context of our epidemiologic study, we do ask about information about diet.
It seems to me in the coordination, and I see the frustration. I was a practicing dentist for 25 years. I'm also celiac free, by the way. So I can understand their frustration. It's mortifying. When you try to go for studies, I mean, the coordination of studies is inherently poor. Absolutely horrible. I mean, even to recently as last year. But we have people that are so motivated in these families. When I would give post-ops to families, you get about twice the support. With autistic families, they're begging for more support. I mean, you're getting tenfold heroistic type of aptitude and findings. And I'm finding more from them than I am from the medical research. And it seems to me we're focusing something wrong here. We should be focusing on the family. They're telling you what's going on, and they're frustrated is because the research is cylindrical. They're not sharing. They're not coordinating at all. And they're telling you what's going on and what's wrong. And we should be focusing on the family and utilizing that as a coordinating factor. Now, I want to get back to diets. I mean, I've got family history with this and the genetic factoring. We got to spend more time looking at the genetics because there is a trigger mechanism. And celiac brew is one of those. Looking at casein as well. There's so many things. And you cannot point to me to a disease factor. Point to one of them. I dare you. And we'll find a dietary problem with it. I mean, diabetes, heart disease, thyroid conditions. You name them, MS, you're going to find a dietary aspect. So part of the problem we ought to be focusing on is the dietary aspects. In aspects to my colleague from D.C., is we ought to be looking at how do we help parents in a dietary format. This is what my experience was. I spent every night after my practice closed going through aisles in a grocery store, looking at everything on the aisle to make sure it didn't have a gluten or wheat. Do you know how long that took? It is unbelievable what these people have to do. Absolutely unbelievable. And we got researchers who don't listen to them. To me, this is just absolutely incredible. And I think it's a slap in the face for these people to be looking at those aspects. And here's how affluent it was. One of my siblings has a son that they said was autistic. Thank God one of my sisters is a physician. In going through this tirade, we found out that she had celiac brew. And she wondered, I wonder if this is the problem for her son. Isn't it interesting? We had a kid who was diagnosed or labeled as autistic, that as soon as we took him off of wheat, gluten, and milk products, this kid sits, reads, does everything appropriately. And I think we can manage this practice a little differently. Sometimes we're in the forest and we don't even understand what we're looking in the trees. Is manage these disease processes is by family, by looking at that as our core group, and then start listening to people, asking a question. That's what we as physicians were taught to do, is ask questions and listen. And I think that's part of the biggest problem that we see in this research aspect, is we're not listening. And I think I see that frustration all over your face. I mean, holy cow, the genetics aspects. Just to give you an example, we were scheduled to be a part of a genetic study for celiac brew, which is inherently a big process to autism. There are 10 kids in my family. Out of all the grandkids, out of the 17 grandkids, 13 have celiac sprue. You think you'd use our family. You think. Boy, sad excuse, we didn't. So we're missing the boat here, and we need to have better coordination, much better than what I'm seeing here currently. So thank you.
The gentleman yields back. Now, I appreciate that this is a hearing that many have waited a long time for and that it's popular, but I would ask, please, that we neither have the positive nor the negative from here forward, if possible. And with that, we go to the gentleman from Ohio, Mr. Kucinich, for 5 minutes.
Thank you very much, Mr. Chairman. In preparing for this hearing, I was looking at some interesting studies and some information to follow up on questions of the relationship between autism and environmental mercury, namely mercury that is airborne as a result of the combustion of coal. The United Nations Environment Program, in a piece called Mercury Control from Coal Combustion, says the burning of coal is the single largest anthropogenic source of mercury air emissions, having more than tripled since 1970. Coal burning for power generation is increasing alongside economic growth. The releases from power plants and industrial boilers represent today roughly a quarter of the mercury releases to the atmosphere. Now, this is from a report called Mercury Control from Coal Combustion. There was a report, actually a study that was done by the University of Texas Health Science Center that showed what's called a statistically significant link between pounds of industrial release of mercury and increased autism rates. The study pointed out that community autism prevalence was reduced by 1 to 2% with each 10 miles of distance from the pollution source. Now, the background of this study was that during the time period studied by the Texas team, they quoted the U.S. EPA estimating environmental mercury releases at 158 million tons annually nationwide in the late 1990s. That's, you know, I'm waiting for more updated figures, but it's probably even greater than that. Dr. Guttmacher and Dr. Boyle, when will first of all, Dr. Guttmacher, are you aware of any studies other than this Texas study that has created a link between neurotoxic chemicals in the environment and increased rates of autism?
I'm certainly aware of other studies that look at, for instance, the one I mentioned earlier that was just published in the last week, looking, for instance, at auto emissions and proximity to auto emissions in pregnancy and early in life as a factor in terms of a causal relationship, who knows, but clearly an association between that exposure and autism rates.
But they've probably gone down since you've had catalytic converters. I'm speaking...
Presumably.
I'm speaking of coal-burning power plants, which are being used and have been used in great frequency over the last couple of decades. Now, are you aware?
I certainly do not know all of the studies in the autism literature. I'd be happy to look into that and provide additional information for the record.
Other than the one from Texas that you're referring to from a couple of years ago, I'm not sure if there's another ecologic study like that. There have been a number of environmental studies that are at the individual level, but not at that sort of population ecologic level.
Well, it seems to me that if not in this Congress, the next Congress, that it would be timely, given the fact that this issue is out there and the amount of coal that has been burned in the last couple of decades, that a study be funded, that we actually look at it and determine whether or not the University of Texas study is confirmed or disconfirmed. The points of this study talk about, of course, exposure, neurodevelopment, the pace of neurodevelopment, vulnerability with respect to age, and also developmental vulnerabilities that begin with pregnant mothers. Of course, genetic susceptibility, as you pointed out, Dr. Gosar pointed out, that's always a factor. But now we know that the amount of emissions may be a factor. That's one of the things that's posited by this University of Texas study. And so, Mr. Chairman, as we move forward with this, because there is inevitably an amount of work that has to be done here that goes way beyond the politics and goes to pure science, or to science, that I think it would be helpful for us to, for the Congress to back a study that would determine once and for all whether the degree to which autism is linked to mercury-releasing sources, specifically the burning of coal, and with respect to the University of Texas study, the amount of emissions and the proximity to those emissions. And I just want to say in conclusion that all these families who are here, you have members of Congress on both sides of the aisle who are dedicated to trying to find out what's going on here and to try to do it in the interest of your family and future generations as well. So thank you for your presence here.
And thank you, Mr. Kucinich. We now go to the gentleman from Pennsylvania, Mr. Meehan.
Thank you, Mr. Chairman, and I'd like to thank Drs. Boyle and Guttmacher for being here today. Let me just start my commentary by saying that as a first-term congressman, we are often impacted by issues that are brought to our attention by the constituents we serve. I can tell you that I don't know of another issue that has affected more of my constituents that have demonstrated a greater degree of frustration than this particular issue. And so it's new to me, and I'm listening to your testimony. But let me ask a question. I know that we saw, you studied this in 2007, we saw 1 in 150 children so diagnosed. And then in 2009, 1 in 110. And now we've diagnosed 1 in 88. So just in this short period of time, and 1 in 54 boys. Have you ever seen anything in which there has been such a dramatic progression in the incidence of diagnosis in a 6-year period, in your experience with the CDC?
Well, most of my experience actually has been within the context of developmental disabilities, and we do look at trends in other developmental disabilities.
Has anything had a trend with this kind of accelerating pace?
So actually, there was a paper published a couple months ago looking at the trends in all the developmental disabilities, and the only one that showed an increase was attention deficit hyperactivity disorder.
Talking about at the CDC, we deal with a broad variety of health crises at certain points in time. Has anything accelerated in your experience to this degree in a 6-year period?
Well, again, relative to my area of expertise.
How about in general? You are in the CDC. What do you know about in general?
Right. Well, again, thinking specifically about what's going on with autism, you know, we have been looking at trends over time, and as you point out, there has been an increase. We do know that some of that increase is due to how children are identified and diagnosed in the community. So there have been changes over time that contribute in part. Our system monitors the number of children. We don't have all the information about what's happening in the context that influences how children are identified.
I guess what I'm saying is, and these are your words, not mine, as we've seen this remarkable acceleration just in the diagnoses, and in your words it was, this is a public health concern. Would you explain to me why this is not a public health crisis? Why this isn't an issue that is on the front burner of the CDC every day?
This is a very important issue to the CDC, and we are using the strengths of CDC to approach this issue. We are monitoring what CDC does, and its excellence is basically tracking and monitoring epidemiologic research and prevention.
And Dr. Boyle, thank you, because I know what you're saying is you're supporting that has been growing. Dr. Guttmacher, the facts are clear. This has been accelerating at a remarkable pace, at least in terms of the diagnoses. What is being done to have a genuine, comprehensive plan in which we are looking for accountability year to year on the progress that's being made and in terms of what we're doing to better understand this issue?
It's a very important question, Congressman. I think part of it, again, goes back to the IACC having been created and asking for it to every year come up with an updated plan. And I can tell you, I haven't checked my emails in the last couple of hours, obviously, but based upon simply the flurry of activity over the last few days alone, there really is work amongst
flurry
multiple...
because of our hearing, or flurry just...
No, because it's that time of year. We're aware that the year has come to a close, and really trying to put together this year's plan in a very thoughtful way, looking at all of the research...
Who's in charge of this? Who wakes up in the morning and says, this is my priority, I am going to drive this train and make sure something happens today? Who's in charge of it?
I'd say there are a number of people that are doing it. The head of the IACC is Dr. Thomas Insel, who's the director of the National Institute of Mental Health at NIH. But there are multiple. And again, I think it shows, you asked about how important is this to CDC. It's very important. I know how it's important, I can tell you, to NIH. It's extremely important to NIH, and that's why, in fact, there are a number of institutes at the NIH that include autism as part of their research portfolio.
What does it take for us to develop a comprehensive national strategy with real accountability and timelines?
I'd say that, again, the IACC in many ways accomplishes that. If you think that that's lacking, then I would think it's a question really for the Congress to figure out how best to put that together, because clearly, as I think the hearing appropriately reflects, there are a lot of medical issues here, but there are a lot of issues about the lives of those who have autism that have nothing to do directly with medicine per se.
I get that, but where is the dynamism in which that emerging evidence is being challenged and being used in a dynamic concept to hurry to a discovery, at least an advance in this, as opposed to what may be just sort of a, I hate to say it, there's so many different aspects of there, but as an outside observer, I see it as being sort of willy-nilly, and this is the next thing that gets funded today and somebody tomorrow, as opposed to a real focus on a critical path.
Again, I think that there are multiple parties involved in this who are really quite concerned about this, who work in a regular way to try to advance this. Frustration absolutely is there, absolutely understandable. But as Dr. Boyle said, I think, in fact, in recent years, we have seen a clearly acceleration in progress in this. Is it sufficient? No. Is it accelerating? Yes.
Well, we've seen an accelerated in diagnoses, so we need to have the same intensity, I believe. Thank you, Mr. Chairman. I yield back.
Chair, at this time, I would ask unanimous consent that our colleague from Florida, Congressman Vern Buchanan, be allowed to participate in today's hearing. Without objection, so ordered. Okay. Glad to have you aboard, Congressman. Now, my friend from Massachusetts, Mr. Turney.
Thank you, Mr. Chairman. I appreciate that. Thank you for our witnesses and all of the folks that are taking the time to be here today as well. I did want to start by just addressing a concern that my colleague, Ms. Norton, had with what can we possibly do for those children that are aging out, so to speak, of the services on that. We did have in the Higher Education Opportunity Act a couple of years ago a provision that was carried in the House, and Senator Kennedy carried it in the Senate for colleges and community colleges to address programs of sustainability for at least those on the spectrum that were able to be addressed and be helped by that. Unfortunately, in the next iteration of the budget, it didn't get funded again. But I think we could all put some attention on that and deal with some families, at least, on that, helping people have that ability. And I would look forward to others on this committee that might feel that that's worthwhile pursuing on that, and we could do that again and perfect it a little bit, please. Dr. Boyle, you mentioned in answer to Mr. Burton's question that since 2000, thimerosal was removed from all of the vaccines except the multi-vial for vaccines on that basis. Can you answer me why, just as a matter of precaution to eliminate that whole issue, it isn't removed from them as well?
Actually, I said since 2001, and I'm not a vaccine expert, but my understanding, and I will clarify for the record about this, is that the multi-use vials are needed in certain context from a international or global perspective. But I'll clarify that for you.
If you would, just as wide as the necessity that they're used everywhere, it could be diminished in some way and substituted with others on that basis, I think would be helpful on that. Also, to either or both of you on that, is there a differentiation between incidence of diagnosed autism in other countries? that as opposed to the United States? Is it region specific? Are there other concerns like that, or is it generally the same pervasiveness throughout?
So in most developed countries that do have data on autism, the prevalence has been comparable, about 1%. There was a recent study that was supported by Autism Speaks in South Korea. It showed a much higher prevalence, at 2.6 or 1 in 38 for a prevalence. That was done very differently. It was a community screening program or a study versus a different method that we use here in the U.S. I do want to mention one thing, though, within the context of our monitoring network here in the U.S. The prevalence varies considerably, so there are some states that have comparable prevalence rates to that South Korea study.
So what are we doing to sort of try to determine if there are higher rates in some states or some parts of some states than others? Are there a good number of studies going on trying to find out what's different about the environment in those areas than others, and how is that all being determined and coming out? What are the outcomes of those studies?
So our monitoring network continues to track the prevalence. We're trying to identify children at a younger age, so we have a component to identify children at age 4. We are doing studies to try to understand what's impacting that prevalence rate, both from a community perspective, understanding how children are identified and diagnosed in the community, as well as changes in risk factors, and modeling how those changes in risk factors over time might have influenced the rate.
So my colleague was talking about diet and other family incidents like that. Is there part of this monitoring that entails going into an area with a very high incidence of autism diagnosis and actually interviewing those families to find out what might be distinctive about their experience or their history?
That's a great question. And actually, we have a second research program, as well as many activities that are ongoing at the National Institutes of Health. So we have a research component in 6 states in the United States to do just that, to interview families, to get more detailed information from medical records, to compare families of children who have autism versus those who don't, and get a better sense of what's different.
At what stage are those studies? I mean, how far have they progressed?
So that's called the Study to Explore Early Development. We've just completed the first phase, so we have 2,700 families that have enrolled in that study, and we've started the second phase. So we are now in the analytic phase of that and really hope to be having data come out in the next year.
And other than a geographic way of identifying those people, are you doing something also with minority and low-income groups to determine why the prevalence is higher there, interviewing subsets of those groups?
So we are incorporating, so our studies try to get everyone in the population, and to get everyone in the population is always challenging. But that's what epidemiology is all about. It's to be representative of the population, so you don't have any bias there. So yes.
Okay. Thank you.
Gentleman yields back. I'll now recognize myself for 5 minutes. Dr. Guttmacher, you're the only pediatrician here today. And one of my other roles in life right now, is, besides serving in Congress, I'm also a grandfather for 7 children, 2 little girls, one 5 weeks old today, and the one will be 4 weeks old on Sunday. So are you saying that somehow that there's a window of the first year that parents should be looking at different behavioral activities in these children to maybe get an earlier idea that the child may be affected?
Yeah, absolutely. We do think the first year and potentially before that is crucial. It's interesting, for instance, that the NIH and others supported a study that was done in San Diego, which involved local pediatricians doing a survey of their patients, a quick office-based 5-minute kind of questionnaire to try to diagnose children with autism at about 1 year of age to see whether this could be done. Not only did that study show that it could be effective, it was so convincing to the pediatricians that when the study was over, and therefore funding it was over, all of the pediatricians in the study elected to continue to do that in their practices because they were so convinced that this was important for their patients. So I think absolutely more and more we want to make the diagnosis early because then we can get interventions and services to kids and the families in a way that we can make a difference, and the earlier we start them, the better the impact.
Okay. Dr. Boyle.
This is key since we don't know how to prevent autism, and we do know there's great benefits from early identification. We want to identify children as early as possible, and CDC has a campaign. It's called Learn the Signs, Act Early, and it's really targeting parents and healthcare providers, and it has tools to really help parents as early as 3 months, 1 month, to understand what the appropriate developmental milestones are. So your daughter, your daughter-in-law, really can take advantage of those materials.
Well, my wife and I spend a lot of time with them, so I mean, it would really be
You
important
too.
also.
Okay.
Well, you know,
Yeah.
I'm always holding them, doing something with them, and the older ones I'm reading to, I should be looking for things that I would never been aware of before. Now, I do represent an area that has impoverished rural areas, and I'm sure a lot of the members feel the same way, because we don't all represent just one group of people, but a lot of people. So how are people in the impoverished areas, how do they get access to this? How do we get to them? How do we give them the opportunity to find out what it is that they need to know also? Is there a method that, I keep hearing people, they can go online. Well, you know, the area that I represent, there's not a lot of people that can go online to do this. So,
well, one thing I think neither Dr. Goodmacher or I brought up today is we represent 2 agencies within the context of HHS, and there are others that are represented in the Interagency Autism Coordinating Committee that are whose voices you need to hear about too. So the Health Services Resources Administration focuses on training physicians in rural areas to really try to target. And then our colleagues in the Administration on Developmental Disabilities also do work here, Department of Education. So there are there's a lot of work here, and you're just hearing really from the 2 of us. And the IACC is really trying, and I know it has its challenges, but it's really trying to bring together all of those voices in the federal government in a coordinated way, so that we can really help everyone, you know, really be the group that reaches out to all.
okay. Doctor, do you have any follow-up?
I would just say that there are various regional approaches. Before I came to the NIH a number of years ago, I was the only medical geneticist in the state of Vermont, rural area, and saw numerous families and kids with autism. And that was part of a regional network that tried to approach the questions, the particular challenges of providing both good diagnosis and good care to kids in rural areas. It's a difficult challenge, as it is in any area that has barriers to access, be it rural or urban. There are various kinds of government programs that try to do that.
No, and I thank you. Dr. Boyle, anything on the horizon at all, anything you see coming that could be a cure?
Again, we've been focusing on understanding the preventable causes versus the cure part.
Okay. Well, I want to take this opportunity. Mr. Burton and I share an awful lot of passion for a lot of different things, but we're both grandparents. I've often said if we could ever exchange and take the place of whatever it is that our children or our grandchildren, we would gladly do so. So I thank you. He's departed again, but what a great effort, and I think Mr. Meehan hit the nail on the head. We will continue to pursue this as long as we can. You deserve an answer, and we'll keep working towards that means. Okay, right now, is Mr. Lynch is not here. Mr. Quigley, Mr. Davis, you are recognized, sir, for 5 minutes.
Thank you very much, Mr. Chairman. Although estimates vary, research on the prevalence of autism spectrum disorders suggests that black and white children are impacted at comparable rates, with lower incidences observed among Latino children. Is there consensus on this data?
You are correct. So our most recent data shows that the prevalence among African American children and white children is fairly comparable. The Hispanic, the Latinos, is lower.
Is it possible that lower rates among Latino children reflect a lack of awareness within the community, and that might be the reason?
That could be the case. And the program I was talking about earlier, which was Learn the Signs, Act Early, we're actually trying to target Latino, Hispanic populations, working with our state colleagues. We have all of our materials translated into Spanish specifically to try to do that. So we are within the context of the work we're doing, really trying to impact that.
Dr. Goodmacher, are you in agreement with?
I'm in agreement and would bow to Dr. Boyle and the CDC for their expertise in this.
It has been suggested that children can be diagnosed as early as 14 months old, giving those children and their families the benefit of early intervention and treatment. However, children of color are routinely diagnosed at a later age than their white counterparts. What barriers exist to early diagnosis of all children, and are there any socioeconomic barriers that prevent parents or physicians from recognizing the early signs of autism among children of color?
I think there are issues of access to quality care, having access to longitudinal care, for instance. The pediatrician or family physician who sees the child, the same provider seeing the same child over time, can more easily pick up lack of appropriate developmental progress, et cetera, than a physician who is, or other healthcare provider who's seeing the child only for episodic care. So I think some of the questions of access, et cetera, no question, for diagnosis is principally made in a medical context. There are issues of access here.
So if a family did not have, say, primary care physicians for both themselves and their children, then it is possible that there might be a later diagnosis than if they had this ongoing care all along.
I think it's possible. Creates, this is, there are obviously many challenges to making this diagnosis earlier would have happened long ago. And this adds, I think, to the challenges for the family, for the healthcare providers in doing that.
Well, let me ask this question. Once diagnosed, individuals with autism spectrum disorders have average medical expenditures between 4 and 6 times greater than the rest of the population. The Harvard School of Public Health has estimated that it can cost $3.2 million to care for an individual with autism over the course of a lifetime. Although insurance covers some of these costs, intensive behavior therapies, often paid out of pocket, can cost as much as $60,000 per year. For families of average or limited means, that means that limited access will also occur to treatment. What level of access do low-income children have to behavior or therapeutic interventions before they reach school age?
That varies by locale, certainly to some degree, in terms of what provisions are based in the community and their level of availability. No question that for any family, even a family of great means, the challenges of appropriately caring for a child with autism are financial challenges along with the other challenges they represent. For those of lesser means, clearly the financial impact can be even relatively greater.
Are we making any real progress with that issue?
I think we're making progress. Again, it's frustratingly slow, but we're making progress in terms of coming up with more interventions that make a difference. And ideally, one wants to have an array of options for interventions, because different interventions will be more successful for one individual, for one family than another, but also that access to them will vary, so that it's one of the reasons for not saying, gee, we're happy we have interventions, but say instead, well, we've made progress with interventions, but we clearly need to develop more.
Thank you very much. And I yield back, Mr. Chairman.
Thank the gentleman. Now the gentleman from Florida, Mr. Posey.
Thank you very much, Mr. Chairman. Dr. Boyle, my predecessor, Congressman Weldon, was a well-respected, competent medical doctor, and a great deal of esoteric expertise on this subject that I'll probably never have. But I gleaned from him some certainty that he felt thimerosal in vaccinations definitely was a contributing factor to autism. And I read not very long ago an article that it said until the wonderful people like us introduced vaccinations to Africa, the African children basically were autism-free. They never heard of autism, never had a case of Down. Are you familiar with that? Have you ever heard that before? Okay. I wonder if the CDC has conducted or facilitated a study comparing vaccinated children with unvaccinated children yet. Have you done that?
We have actually done a number of studies looking at the relationship between thimerosal vaccines and autism and other developmental disabilities. And there have been, since, actually over the last decade, there have been numerous studies looking at the relationship between vaccines and aspects.
That the CDC conducted?
Some of them were conducted by the CDC, others were conducted by
How many would you say, would you estimate?
I would actually have to check what the specific numbers, but I know there were two. One large study looking at various neurodevelopmental disorders, and the second one that would focus specifically on autism. And those were fairly recent studies.
Would you see that my office gets a copy of those, please?
Of course, I'd be happy.
Do you believe additional study would provide useful data in assessing the safety of childhood vaccines?
The IOM has evaluated this issue back in 2004 and again most recently in 2011. And their conclusion, again, was not just looking at the work that was done at CDC, but with the total body of evidence, was suggesting that vaccines and their components did not increase the risk for autism.
My time is very limited here. So clearly, definitely, unequivocally, you have studied vaccinated versus unvaccinated.
We have not studied vaccinated versus unvaccinated.
Oh, okay. Never mind. So just stop there. That was the meaning of my question. You wasted 2 minutes of my time. What steps has the CDC undertaken to ensure the integrity of the research that was performed by Dr. Thorson, who, as you know, has been indicted for misconduct and misallocation of resources?
So Dr. Thorson, who was a co-investigator on a couple of studies that came out on autism, was really just one investigator. And that body of evidence related to vaccines and autism.
All right. Have you gone back to validate the variety of studies he participated in? I mean, this guy is a humongous scumbag, one of the most wanted men on earth, and you relied upon him for data to determine whether thimerosal had a negative effect?
So two studies don't conclude a body of work. The body of work that's relating vaccines to autism is a large collection of studies.
You told me you only had 2 studies relating to vaccines, vaccinated and unvaccinated, so you must figure 2 studies must have some weight. Running out of time quickly here. You mentioned that you only have thimerosal in multivial. Why is that?
I was actually going to get that information for the committee.
Okay. Because I would think if they only have it in multivial, if they eliminated having it in all the other vials, there was a reason.
There is definitely a reason, so I was going to clarify that. Yeah. There are single-dose vials and multi-dose vials.
And they took it all out of everything but the multi-dose vials.
That's correct.
Okay. How many multi-dose vials are there?
That I can provide you that information.
Okay. I've seen a chart that ranks the longevity of the 30 nations with the best mortality rates in the world, starting with Iceland, Sweden, Singapore, and on down. We didn't even make the top 30. We're the 34th. And ironically, we require more vaccinations than any other country that's healthier, has a less mortality rate than us. Do you see any correlation whatsoever, either one of you, to the 34th worst mortality rate and the most vaccinations to the ones with the least required vaccinations and the lowest mortality rate? They also have children that, past age 20 in those countries, too.
There are many factors obviously involved in longevity for any country. The one thing we do know about vaccinations is that they are among the major public health reasons why generations today live much longer than in previous generations. They are perhaps the most successful public health movement in the world.
Nobody's talking about or against vaccinations.
Well, I was just trying to answer.
We're talking about thimerosal in vaccinations.
I was trying.
And multiple, bomb blast of vaccinations in short period of time on very, thank you, Mr. Chairman. My time's up.
I'm sorry, gentleman's time has expired. Did you want to answer?
No, I think I had an opportunity. Thank you.
Okay, very good. Then the next person, the gentleman from Kentucky, Mr. Yarmouth.
Thank you very much, Mr. Chairman. Thank to the panel for your testimony. Those who know me, and now those who don't, I wear these bracelets every day. These are bracelets that were the brainchild of a young woman in my district who's now 16. She has a younger brother who's autistic. She started at 11 raising money for research in autism by selling these bracelets for $3 a piece. She's now raised over $600,000. Her name's Michaela Riggle. She's already financed a $250,000 study in one aspect of autism. And I raise that not just because I like to brag on her, because she's an incredible person, but also to illustrate the kind of civilian activity that is going on in this field, and it's represented here clearly today. We are here as representatives of the government trying to find out whether there's anything the government should be doing that we're not doing. And obviously there have been a lot of concerns expressed here about frustration and the activities of government. A lot of what we can do is fund things. We do know how to spend money. And we do have this across-the-board cut coming up, the so-called fiscal cliff, if we don't act. We're very much dealing with spending priorities. Last year we, for instance, passed a defense appropriation bill that allocated $2 billion more than the Defense Department actually requested. We still give oil companies $4 billion a year in subsidies that they don't say they need. So my question is, if you had another $2 billion or $4 billion, what could you do with it? And how would you spend it?
One thing I would say before I would spend the dollars is I would not want to displace the private efforts, the efforts that you mentioned, because I think part of the reason why autism research advances is the combination of federal funding, but also having private organizations, advocacy organizations who have research efforts as well. And often these research efforts there are many things I mentioned today already in my testimony that are supported both by federal dollars and by private dollars. And also, of course, the important input of the families, the individuals with autism who themselves inform the research and help shape the research agenda. So no matter what the money, we should keep that partnership. I think in terms of money, clearly, I think as Dr. Bose also talked about, that we can see there are particular scientific opportunities right now in terms of better understanding environmental factors. Many people I know have been concerned that there's been too much focus on genetic factors in autism. I would argue that, in fact, understanding those are very important for understanding the environmental factors, because we know it's a combination of both. So to figure out the combination, it's great that we better, still not fully, but better understand the genetic ones. So now we can focus more on what the environmental factors are, because after all, those are the ones that we can influence and control. So in terms of investments in that, and again, investments in looking very early in life to better figure out what the etiology is, but then also investments in terms of interventions so that we have more effective interventions and more options in terms of interventions. And again, I think more research and more work in trying to figure out how to best have an impact on the lives of those living with autism, both in childhood but very particularly in adulthood as well. So that I think there are a number of areas where we can wisely invest money.
Dr. Boyle?
Well, thank you very, very much for the question.
I wish I could offer you the money.
Yeah. But anyway, we do get requests all the time from states, so we fund states both to do surveillance and to do research, and particularly in the area of surveillance, the state has good knowledge about what's going on within their context, so they can plan for services. They can address some of the many issues that came up today about disparities in diagnosis among racial and ethnic groups. I mean, that would be one of the places we would really like to be able to fund more states. And similarly, to get answers faster. We have worked very hard over the last 5 years, and it's not really we, it's our academic and state partners who have worked very hard over the last 5 years to develop our research base. And we're just at the cusp of actually being able to explore that. You know, more dollars would actually allow us to do work faster, and to really be able to put as much energy into getting good answers for all of the questions that we heard today.
Okay. Thank you very much for your testimony.
Thank you. Now we'll Mr. Smith from New Jersey.
Thank you, Mr. Chairman, and I appreciate the committee's allowing me and others to sit in on this. And I want to thank Dan Burton for his extraordinary work. He is truly a champion. I sit next to him on Foreign Affairs, and he's a great member of Congress and a great leader on combating autism. Dr. Guttmacher, in your testimony, you state that since passage of the Combating Autism Act, there's been a groundswell of activity suggesting, and I think unwittingly suggesting, that this has been about a half-dozen-year effort. As you may know, I introduced legislation as far back as 1997 that became law in 2000 as Title I of the Children's Health Act that established the Centers of Excellence, the Interagency Autism Coordinating Committee, and really began a robust effort that continues to this day. And, of course, the reauthorizations have been very important. My point is, we've been at this in a comprehensive way for more than a dozen years, and there is a sense of impatience that we all have. Frustratingly slow, I think was the word that was just used. But I want to just make a point. Resources often follow demonstrable need. I know that we were able to marshal huge amounts of money to combat the AIDS, the pandemic of AIDS. And Henry Hyde led the effort. George Bush, it was his idea. And we spent billions in combating AIDS, particularly in sub-Saharan Africa, because the demonstrable need was married up with the resources to try to make a difference. I think it hurts the effort, but we have to be accurate. When the 1 in 88 number was first released, horrible number, terrible number, the Associated Press, Mike Stobbe writes on March 29th, lead, autism cases are on the rise again, largely due to wider screening and better diagnosis, federal health officials said Thursday. Dr. Guttmacher, you were asked in the New York Times article about that question of epidemic, and you said, yes, it seems to be more common, but the jury is still out. The bottom line is you asked two questions rather than perhaps answer it. And again, you've got to go where the science is, and I deeply respect that. But it is now a couple of years later, and I would appreciate it if the jury is still out, whether or not it's just better surveillance, especially in light of what Autism Speaks has discovered in South Korea. The 1 in 38 study that they funded makes it very clear that when you go further into a study, into the weeds in terms of asking the right questions, more rather than less seems to be the case. And I'm wondering if you could comment on that South Korean study. Secondly, so jury out study, if you could speak to that. Africa. I chair the Africa Global Health, Global Human Rights Committee. I've been working on the Foreign Affairs Committee for 30 of my 32 years in the U.S. House of Representatives. We never saw a prevalent spike like we've seen on autism in Africa as we have seen in the last 15 or so years. I had the first hearing ever on global autism, and what we got back from those who testified was that and the WHO backs us up, there are probably tens of millions of cases of autism in Africa, sub-Saharan Africa in particular, and nobody knows why. I was in Nigeria giving a speech on combating human trafficking, and a man came up and told me, he says, you can't believe how many children in Nigeria are living with autism, and of course in a developing country, it is very, very hard to overcome that. It's hard in this country, even harder there. So if you could speak to those issues. Dr. Zaharati, who's our principal investigator in New Jersey, he is here today. He's a very good friend, a very, very competent man. My question regarding New Jersey, we have the second highest rate. Are the other states just as high, but they haven't done, or the methodology has not been as keen and as effective? Again, suggesting that we have a worse epidemic than someone suggests. Your thoughts, if you would, on whether or not gut flora is a contributor. We know immunity is found in the intestines. There has been, I think, a nexus between the two. There's very suggestive research on that the lack of the gut flora, particularly in women who are pregnant, may contribute, we don't know, to this problem. And finally, and I'm almost out of time, but the idea of, like with AIDS research, having an Office of AIDS Research that can really number out what their recommendations, put price tags to it, shouldn't we have that also in our efforts to combat autism?
Congressman, let me try to respond to all of those questions. Please let me know if I haven't responded to all of them. First of all, I certainly do not want to leave the impression that it's only been in the last couple of years that the IACC has had a role. I know that your long-term leadership of the Autism Coalition made sure that that was put into effect a number of years ago, and I think for as long had an impact. I was only trying to emphasize I think there's been, as it's both grown in terms of membership and also I think gotten more experience, it's become more effective with time is what I was trying to say. I think in terms of the South Korean study and the 1 in 38, there are obviously some methodologic issues with that, but there's some methodological issues with almost everything. I think it's a very well-done study. Does it show that the rate is increasing? Unfortunately, we don't know because if there was not a precursor study in South Korea, it will be very important and interesting to see a few years from now were that repeated in South Korea with the same rigorous methodology, what numbers they see. Clearly, we know for sure that some of the increase in terms of the rates the CDC cites, and again, I would bow to Dr. Boyle on this because she has more expertise. Clearly, we know that much of that is due to increased and better diagnosis, which is laudable. Whether that explains the whole thing, I don't think that we scientifically know for sure. I think that there's enough of a reason to be, to some degree, obviously this is a hugely important question. To some degree, it's not so important because regardless of the answer, we know, A, that there are environmental factors at play here, and we need to identify them. B, we know it is a common public health problem, so we need to take it seriously. So regardless of whether the rate is increased or not, hugely important question to answer, but in terms of what we do, much of what we do would be the same in either case. I think, for instance—
the time has expired, so if you could just summarize.
Okay, quickly, let me answer the gut flora questions. I think it's an important one. It's those kinds of questions. In fact, we obviously know that the rate of cesarean section is much higher than it used to be. What's the difference between being born by cesarean section and born vaginally? One of the big differences is exposure to gut flora. What gut flora, what flora colonized the gut of the infant at birth? Could that play a role? We don't know. It's one of those many environmental things that we should be looking into.
Thank you, Doctor. Now we recognize the gentlelady from New York. Mrs. It's just nice to have you with us.
Thank you, and thank you for calling this hearing. Autism is becoming a growing epidemic in the United States, and it definitely needs to be addressed. And I want to compliment, really, Congressman Burton for his leadership. He's not here now. I think is he here? Yeah, and for being the chairman of this committee and doing such a fine job. But you have really focused on this, and I think you've made some progress, and I want to thank you for your leadership on this issue and so many others, and express my gratitude to you and how much I've enjoyed working with you. Now, the numbers that he pointed out earlier, that it used to be 1 in 10,000 kids got autism, it's now 1 in 88. And I'd like to ask Dr. Boyle why. And I don't want to hear that we have better detection. We have better detection, but detection would not account for a jump from 1 in 10,000 to 1 in 88. That is a huge, huge, huge jump. What other factors could be part of making that happen besides better detection? Take better detection off the table. I agree we have better detection, but it doesn't account for those numbers.
So just to put it in context, better detection is accounting for some of it, like
right,
Dr.
I know
Marcus
some,
said.
but what other factors? I don't want to hear what other factors.
Our surveillance program counts cases of autism and establishes the prevalence. It doesn't tell us all the answers to the questions as to why.
Okay.
So we are doing a number of studies to try to understand the why. And one of the things that we've looked at, we've tried to look at what's changed in the environment of things that we know are risk factors for autism, things like preterm birth and birth weight and
Well, are you looking at vaccinations? Is that part of your studies?
So let me just finish this one. So
No, I have a question. Are you looking at vaccinations? Is that part of pardon me?
So there is a large literature, as I mentioned.
Are you having a study on vaccinations and the fact that they're cramming them down and having kids have 9 at one time? Is that a call? Do you have any studies on vaccinations?
There have been a number of studies done by CDC on vaccinations as well.
Could you send them to the ranking member and the chairman here?
Yeah.
Now I want to tell you a story. We all react to our lives. And I remember people talking about hormone replacement. It's going to save women's lives. You got to take it. Yet every nurse I talked to said, go to the bank, it causes cancer. Every relative that got cancer said they got it because of the hormone replacement. I'm hearing the same kinds of stories on vaccination. I must have had 50 different parents write me or come to me and say I had a healthy child, yet then they had 10, 9, 6 vaccinations at one time, and that child changed overnight and was knocking their head on the wall, and it was a changed child. In fact, I had a family in my office today where the mother broke down crying, saying my child was wonderful, bright, precocious, talking. She took those vaccinations, and the child became very incredibly sick and has never recovered. So I'm interested in any studies on vaccinations and trying to understand that. Now, it used to be that you'd go and get a vaccination. My child never got more than 3 at a time. And in the state of New York, children are recommended to get 6 shots every 2 months throughout the first year of a child. And my question is, why does the schedule of these vaccinations require a child to receive so many shots in such a short period of time? You could plan those shots over a period of time. I'm for vaccinations. They prevent disease. I'm totally for it. But why do you have to cram 9, 6 at one time when the verbal evidence seems so strong from so many people that they had a healthy child until they got vaccinated? And you've got to just listen. I remember smoking. I was on the city council. I sat through so many hearings where they vowed smoking was not bad for your health. It's a common sense that it was bad for your health. Then finally, the Surgeon General said it was bad for your health. The same thing seems to be here with the vaccinations. There's too much verbal evidence coming from parents where they break down. I had a normal child. I gave them a vaccination, and then they came down with autism. So it seems to me we should. I'd start spacing it out. Why do we have to have 9 vaccinations, 6 vaccinations every 2 months? Why can't we do it over 2 or 3 years and space it and wait for the scientific evidence or whatever?
Gentlelady's time has expired.
May she answer that question?
If you could summarize.
Sure. There is a federal advisory committee that determines the vaccination schedule. And the reason, and again, we'll clarify this and get you more information, but the reason they cluster the vaccines is really to try to make sure that everyone gets it. People don't, again, we're trying to make sure vaccines go to all children. And not everybody goes to the doctor routinely, so they use that opportunity to make sure that happens.
Thank you. The Chair now recognizes the gentleman from Florida, Mr. Buchanan.
Thank you, Mr. Chairman. I also want to recognize, Congressman, for all your leadership over the years on this issue. A lot more work to be done, but I want to applaud you for that. Let me just focus back on the vaccine. Some of my colleagues have brought that up today. Is it true that we have over 40 vaccines, and I'm not against vaccines, all of them either, but let me just say, because I know there's a lot of evidence that they're good, but don't we get like 40-some vaccines, our children today? Is that the number I'm hearing, upward of 40? Yeah, either the doctors, just out of curiosity.
There's exact number, and it varies somewhat. I think 40 is a little bit high, but it's
why would it be, just to point it out, why is it twice what France is, 3 times Finland, a lot of these other countries? And I know, because there's a lot of people that move in and out of France, a lot of diversity. I just don't understand why our kids are getting so many shots. And I think of my father-in-law on a different standard, just in terms of common sense, where he's elderly, but he's taken 8 pills. They found out that a lot of them have effects and impacts on other pills. And that's why I don't know that we're spending enough time and energy looking at this, where our kids are getting twice the shots of everybody else. And I just have, my sons, it seems like they're older now, in their late 20s, but they might have had 7 or 8. And I'm just going by people that I represent in our area that feel strongly that this has to be looked at in a very, very aggressive way, that if we're over-vaccinating our children. And I'll doctor either one of you.
We know vaccines save lives. There was a recent analysis that was presented at the pediatric meetings in April, and I actually have the numbers from that, where it was estimated that 42,000 lives were saved, 20 million cases of disease were prevented, and $13.6 billion in direct medical costs were saved, and that's for each birth cohort. Again, there are complexities in terms of the schedule, there are complexities in terms of the types of vaccines, and this is all carefully thought out by an advisory committee that oversees this process.
Have they looked at the impact that and I'm not a chemist or anything, but when you put all these drugs or vaccines into children, the impact that these various vaccines might be having, combinations? I mean, here's what I get back to. We've got in 2005, according to autism, it was 1 in 166 children. Today, it's 1 in 88. We brought that up a couple of times. Boys, it's 1 in 54. They're saying 40 years ago, whether it's true or not, this is what they're saying. I'd be interested in your thoughts. It's up 1,000%. So when you look at 40 years ago, maybe we got 6 shots. Now we're getting 40 shots. Is there a possibility of any correlation? Either of you.
I mentioned earlier, I mentioned earlier that there is a body of evidence now, it's accumulated over the last 10 years, looking at the relationship between vaccines and autism. And that was evaluated in 2004, again very recently in 2011, which didn't support an association between vaccines and autism from a population perspective.
Doctor, do you have anything to add to that?
I would agree. That's correct.
Let me ask you the other thing. They're saying that the person in their lifetime, the care cost is $2.3 million. Do you agree with that number for autism? That's the number I got.
I don't have a specific number. I'd be happy to provide additional information for the record on.
But I think it's $2.3 million, and they say that it costs the country. I didn't realize it was to this magnitude, $137 billion a year in annual cost this country for care of autism. Do you agree with that number? Either of you?
Again, I would not have the data to agree or disagree. I know that it's a high number.
Okay. Well, I just want to let you know we've got to spend more time and resources and fix this problem, because it's obviously out of control. Thank you. I yield back, Mr. Chairman. Yes.
Thank you very much. I'm just sitting here and I'm listening to all this. There's something wrong with this picture. There's something wrong. And, the gentleman, I thought, asked some very good questions. As a matter of fact, the whole panel. When you've got this combination of shots, and you go from 1 in 10,000 to 1 in 88, it seems to me somebody would say, wait a minute, let's put the brakes on this, and at least let's try to figure out whether, if I'm giving a baby 9 shots in a day, whether that, how much impact that's having. I don't know how it just seems logical. If they gave me 9 shots, I would, I don't know what that, and then I know you said there's a body of evidence with regard to vaccines. Mr. Chairman, I don't know where we go from here, but it just seems to me somebody ought to say, wait a minute, let's put some brakes on this, and not saying don't deal with vaccines. Just look at, whether the multiple shot situation is causing this. And I wish you could see the people behind you. They're grown men that have been crying behind you, and women crying. And it's just so I just hope that we can. You hear the frustration coming from here, and I'm just sitting here and I'm just saying, wait a minute. It just seems like somebody would say, is there something maybe there is an issue here, and if we're going to err, let's err on the side of keeping children safe, even if we have to, do a pause and give one shot a day. Thank you very much. I thank the gentleman for yielding.
If I may take a liberty of the Chair for a moment, it is our intention to include in future hearings, and the gentleman from Indiana is here, a narrow but specific request, and I put both of you, even though you may not be the witnesses, of the question of drug interactions where the FDA approves individual drugs and individual vaccines, but by definition does not necessarily thoroughly study interactions of any sort that can happen with 1, 5, 9, 20 different ones. That's a different hearing, but it is one that we wanted to talk about because one of the questions that we see every day, and I appreciate the understanding, is that both prescription drugs and non-prescription drugs, when interacted, do things that were not tested by the FDA. So as part of our ongoing relationship with the FDA primarily, that is a series of questions we expect to explore, not because we want to further burden and slow down the approval process, but because ultimately that is one of the answers that we are only now getting more evidence that there has to be a systematic approach to dealing with all of what we put in our bodies. And Mr. Gosar, when he was here earlier, talked about food being something that you can't control, but at the same time, drugs have to be looked at in terms of what somebody may eat or drink in proximity to. So I'm not asking you for any information today, but I did want you to be aware that we have done a number of things with FDA, and we do intend on going down some path related to that, and I thank the gentleman for bringing it up. We now go to the distinguished and patient gentleman from Utah for 5 minutes, Mr. Matheson.
Well, thank you, Mr. Chairman, for holding the hearing, and thank you. I'm not a member of this committee, and I appreciate your allowing me to sit in and participate in today's.
Well, you may tell your friends, this is a committee that represents all jurisdictions of all parts of the Congress, so we would be loath not to include people from the other distinguished committees that we often ask the same questions on the same subjects with.
I certainly appreciate that, Mr. Chairman, ranking member, and I appreciate the witnesses being here today. We've heard a lot about the 1 in 88 number. I come from a state where it's 1 in 47, and I've heard a couple of other members ask questions about differences in incident in different regions, and I'm one that represents a state that's sort of at the one end of the scale, from Utah. And I've heard a lot about this from my constituents, and I've always been an advocate for responsible funding and research for NIH to try to figure out what's going on with this issue. I'd like to ask both of you if you can tell me, based on your organization's research, have you been looking at these geographic disparities, where a state of Utah is 1 in 47 instead, and can you offer me any information that helps me understand why my state has a different number from the national average?
Well, I would go back to some of the comments I made earlier, in that differences in how states identify and serve children. Since our program, our tracking program, utilizes those sources, those record sources to identify children, and that varies from state to state, and that those numbers in many ways are a reflection of that. Some of our states don't have access to education records, and since we are dealing with 8-year-old children or school-age children, and they're served through IDEA and special education, that makes a difference as well.
Can you tell me, though, I appreciate there may be differences in methodology for collecting, but is my state better at it? Is that what you're telling me? Or is there something else going on in my state? Has there been any conclusion to these studies that talk about how things are done differently in different states?
So we are looking at both differences in how children are identified, right, as well as differences in risk factors across states to try to get a better sense of that.
Is there a target date when there may be a result? You say you're looking at it now. Do we know when there may be some answers?
Well, there are some answers. So from the report that we put out in 2008, what we could see is that children who were coming into the system were more likely to have a community diagnosis, so their community physicians are more likely to be aware of autism and coming into the system. And that's changed over the 10 years that we've been monitoring.
But I understand that there are differences. I'm trying to figure out, have you validated that that's what's going on, whether there's a 1 in 47 rate in Utah? I'm just trying to figure out why the number is different in my state than
one other example is that we are actually doing, Autism Speaks is funding a special study in South Carolina. So using one of the ATOM sites, they're looking at it in a much more in-depth way to see, in fact, is that number in South Carolina low? So again, it's a puzzle, and we're putting all the pieces of the puzzle together that way.
Yeah, look, I'm not a statistician. I just see a big difference in numbers. So I think it would be helpful if we could understand why that number is different. In my limited time, I'd like to ask one other question. Can any of you tell me about any new therapy approaches that are emerging for effectiveness in treating autism?
There's certainly some therapies in terms of behavioral interventions and other kinds of things that are emerging, that are being developed. In terms of something like a medical therapy, I think we're much farther away from those kinds of interventions, though one would hope that eventually we would have those to offer as well.
Thank you, Mr. Chairman. I'll yield back.
I thank the gentleman. Would the gentleman yield his remaining time to Mr. Burton?
Thank you, Mr. Chairman. I just have one question. Why did the FDA and HHS take thimerosal out of all the children's vaccines except just the one or two or three? I mean, I'd just like to know why they took the thimerosal out if there was no problem and leave it in just a couple.
I think neither of us are vaccine experts, and we'd be happy to look into that and provide additional information.
Well, I'd like to have an answer, because I think most people would really like to know. Thank you.
I thank both of you. I thank you for agreeing to answer that for the record. And by unanimous consent, I allow Mr. Posey to ask one additional question to this panel, then we're going to go to the large second panel.
It's to you, Mr. Chairman. In the course of answering this, one of the witnesses told me that the fugitive doctor had been involved in a couple studies with CDC, and I have information here that he was involved in 21 of the 24 studies, and I would like to submit that to the record, Mr. Chairman.
Without objection, so ordered.
Thank you.
Again, I'd like to thank our distinguished first panel. Again, we will accept additional information for the record. If I know you've been in front for a long time, I might suggest that you take advantage of our conference room in the back and leave when you choose to, but if you can stay for a while and watch it on the monitor, it may help you in additional items for the record. So with that, we're going to suspend. We're not going to leave the room, and if the clerk would please change over for the next panel so we can get started immediately.
Oh, thank you. This is fresh. Jake, hi. Did you go up and like talk to the or is that like is there like
no, we're actually stay close to our seats because we're going to
I respect that totally. I just wanted to thank you. I got the drift. I got
This hearing on rising autism rates will continue. The committee hearing from a range of advocacy groups next. Bob Wright, the co-founder of Autism Speaks. They'll also hear from Scott Badish, the president of the Autism Society. Also, Safe Minds board member, Mark Blacksell. And there's also the coordinator of the Asperger Initiative, Bradley McGarry. So we're waiting for this hearing to get started again.
Thank you. Thank you. Ladies and gentlemen, we really did not recess. So if our witnesses would now take their assigned seats, I suspect the second panel will take a very long time but be equally interesting.
While we wait for the panelists to be seated, look ahead to tomorrow morning on our Washington Journal program. Our guests are congressional historian Norm Ornstein, who'll talk about the proposed changes to filibuster rules in Congress. And later we'll hear from Politico Stephen Sloan, a tax reporter who'll discuss tax credits slated to expire at the end of the year as part of the so-called fiscal cliff. That's on C-SPAN every day starting at 7 a.m. Eastern.
Starting with Mr. Bob Wright, who is the co-founder of Autism Speaks. Mr. Scott Badish is the president of the Autism Society. Mr. Mark Blacksell is a member of the board of directors of Safe Minds. And I would ask that Mr. Kelly introduce and make a short statement about the witness he helped bring here.
I thank the Chairman. One of the great honors I have is representing Northwest Pennsylvania and Mercyhurst College. Mr. McGarry, Bradley McGarry, is with us today. Mercyhurst is one of the leaders, if you didn't know this, around the country, starting in 1986, addressing these types of problems, and they have been the forerunner. Mr. McGarry has spoken all over the country about the initiatives that can be taken and the ability to help those with lesser degrees of autism to integrate into society and make great contributions. So, Mr. McGarry, it's so nice to have you here and representing Mercyhurst. You do great things. And in 2008, your program, the Asperger Initiative at Mercyhurst, is one that's being looked at all over the country and is a perfect model that lets us to go forward and address some of these issues. So, Mr. McGarry, thanks so much for being here.
I thank you both.
I yield back, Chairman.
Thank you. And we now recognize Mr. Michael John Carley. He's the Executive Director of the Global and Regional Asperger Syndrome Partnership. And Last but not least, we recognize Mr. Ari Naiman. He is the president of the Autistic Self-Advocacy Network. Again, as you saw in the first panel, pursuant to the rules of this committee, I'd ask you all rise now to take your oath and raise your right hands. Do you all solemnly swear or affirm the testimony you are about to give will be the truth, the whole truth, and nothing but the truth? I have carefully viewed and all answered in the affirmative. Please take your seats. You are a large panel, and you have a lot to say. I would only mention that there are 20 groups behind you who are not fortunate enough to be seated with you. So please, to the greatest extent possible, make sure you finish right at 5 minutes so that we can get to Q&A, much of which will help with issues that may be beyond your opening statements. With that, we recognize Mr. Wright. I'm afraid your microphone is not quite on or close enough. Could you also pull it a little closer?
Okay.
There's a sort of a skill we gain here of getting to the mic and really getting to it. It goes with being a congressman, I'm afraid.
Let's see how we do here.
You have what it takes.
Okay. Well, thank you, Chairman Issa, very much for having us, and Ranking Member Cummings, thank you so much for being here. I also want to thank Dan Burton for all the work that he's done over many years to bring awareness and attention to and discussion of and action on autism. Very, very important. I'd also like to recognize Mr. Smith, who has done an extraordinary job as well all over the country and with the coalition and many others, and I'm personally involved with him in many, so thank you for everything you have done for all of us. I want to say I'm here because of my grandson, Christian, who's now 11 years old. And my daughter, Katie, is sitting back here, and my wife, Suzanne. And he was a boy that was 2 years old, and we thought he was very precocious. He seemed to be brighter than average. He walked early. He had enormous vocabulary, and then he lost everything. And I'll tell you, without any secret, that my daughter, firmly believes that vaccines were the relationship that triggered him into this pit. So we lost a little boy that we knew. It wasn't like he was a disabled person who got more disabled. He was a boy, and we lost him. And that's what led us to found Autism Speaks. We could take care of Christian, but we saw so many others out there, and I traveled around the country, and I sat at meetings similar to the meeting you're having here, where I would ask questions about autism. I went to universities, I went to medical schools, and I got the worst answers imaginable. Actually, I heard some of the same answers here just a few minutes ago in the panel. They must be, they're on a Twitter thing or something. It was, we don't know, but we're sure. Or it's, we're sure, but we don't know. But we really don't know, but we're sure. And that was a lot of the issues. Why are the numbers so high and so forth? So we got into this and said, we called around to find like-minded people, and that's how Autism Speaks got founded. And we've been fortunate. We've raised a considerable amount of money. We have 250 full-time employees around the country. We have 90 walks. We have 400 and some odd thousand will walk for us here. We have activities outside the United States. But all of that's based on that little boy. And the fact that in all my business career, I was shocked that I was so ignorant of all the situation. And then when I got into it and tried to learn, I was even more shocked that nobody was helpful and that we were just trapped in a maze here of obviously escalating issues, all kinds of things. So I'm going to try to answer a couple of things, or at least bring some help to you. We talked about the 1 in 88, which is exactly that is the U.S. number. Now, the CDC's is what they call a passive. It's a passive resource. They go around and they look at medical records that are existing. That's a variable. And they also look at school records. That's a variable. They do not talk to children. There's no clinical evaluation. They don't talk to parents or anything. And that partly accounts for some of the differences when you go around the country. Some schools have better records. Some schools don't. So whatever. And that's what they do. The Korean study that we financed, which is the most, it's the gold-plated model on how to do this. We went through the same process in Korea with Koreans, with Japanese, with Americans. And we ended up finding out that there was about 1% of the population, which is just what we had here. But then a second thing happened. Parents wanted to offer comments about what we were doing, because we were only doing the school records and all that sort of thing. And the school district said, fine, it's a 100,000 population area in Seoul. And the school, we asked parents that wanted to come in that they could come in and offer comments and so forth. Well, they came in and had all kinds of issues, and we separated them out. It took 2 years. And out of that, we actually had 1% more of the entire community, of that same community, diagnosed with autism. We brought people in. And so the number is 2.657%. I have no reason to believe that that number won't be duplicated in the United States with that methodology. That's why we're financing this effort is to convince the CDC that they don't actually have a disagreement with the number. Their position was, we don't have any money. We can't afford that. That costs more money. We only do this. And that sort of speaks for itself. But I'll also tell you that—
If you could do that in summation, please.
Yeah. I'll also tell you that we have— they spend almost no money on autism, $20 million, $30 million, including all of the safety issues. We could fix that in an hour for about $35 million a year on top of what they do. So the name of this committee, the oversight, government reform, there's a real issue there. I wish they weren't even involved with us, but they're the only ones that did prevalence. We are on page 7 of their two-page top priority list, and autism is right at the bottom of it. And I don't know why Dr. Boyle, but the nature of, I guess, being in a larger thing, they won't want to say, we have no money, we don't have any priority, I can't get anybody to hear, and I don't complain enough. So this is about speaking up.
Thank you very much. And we now go to Mr. Badish. With the same microphone problem you will all have. It's an acquired skill, and I appreciate you all for learning it.
Thank you, Mr. Chairman, Ranking Member Cummings, and the other members of the committees. My wife and I are the very proud father of Evan Badish, who's a 25-year-old son with autism who attends Marshall University, which, like the other school represented on this panel, is thriving and helping so many with autism. But he is one of the more fortunate with autism. The Autism Society of America is the nation's largest and oldest grassroots organization dedicated to the autism spectrum. As has been discussed today, the incidence of autism has shown marked increases in CDC surveillance rates, currently at 1 out of 88 births. Many children and adults may not be properly diagnosed, and this number may actually be higher than the actual incidence. We applaud the work of the CDC and appreciate the partnership we have with the CDC, and particularly efforts we are working with the CDC on addressing better some of the questions asked earlier about how we can increase the growing disparity of the autism diagnosis rates among people of color and other ethnicities and geographic location. We would suggest that currently the services for autism are difficult at best to navigate, and often when services are provided, they may not be individualized or be the best approach for the needs of the individual. The Autism Society is about helping people today and preparing them for tomorrow, and we believe that government services, if funded by government dollars, should have focus on advancing an individual's quality of life in measurable and meaningful ways. We need to re-examine how government services can be provided, not on a limited definition of services, but rather based on an individual's needs. As I noted today, there is a significant disparity in the need for available funds for both long-term and to support people with disabilities. This disparity has resulted in very long waiting lists for services throughout our country, and estimates have that waiting list being anywhere from 80,000 individuals nationally to as many as 200,000 people who go without services each day. Meeting this significant need will not only require expansion of services, but we believe it requires us as a society and government to think differently about the way services are delivered. An individual today who is diagnosed ineligible for services and then put on a waiting list is denied the critical services that we all know could help him or her move forward in addressing quality of life needs. We recognize that funds are limited, and we would encourage the committee to examine ways that if funds have to be cut, that they not be cut at the expense of individuals, but at the expense of unnecessarily duplication and administrative services. We also would encourage this committee in its role to look at the public schools. Public schools are required by law to provide every child with an appropriate education, and unfortunately 50% of students with disabilities are either dropping out or not graduating or not receiving appropriate degrees. This is very difficult when we look at how to help those children in adult life. We also believe that government services must be outcome-based, and we must encourage that those services aim to help a person maximize his or her independence and self-sufficiency. And we also have to take a recognition that as a nation, while we are very concerned about an unemployment rate when it goes above 5 or 6%, the reality is that for the individuals with people with disabilities, that rate is as high as 78.5%. Government's response are most effective also when resources are available under one umbrella, and any parent or any individual who has had to navigate the system will say it's impossible to navigate. The committee needs to also look at how we can more effectively, and we would argue at a much lower cost, coordinate the government's response through a one-stop model or a centralization of information. We also would encourage this committee to look at the issue of Medicaid portability. When a person moves from one state to another, he or she loses their Medicaid community support services and has to start over again. This is particularly of concern to military families when they get relocated from one base to another. Finally, I want to mention about the Combating Autism Act and the Interagency Coordinating Council. With all respect to our prior speaker, we would disagree with a lot of what he said. This is a group that in concept could do a great job of coordination, but in reality it's not. If a body is going to be, in fact, a coordinating body, it has to include public, private and not-for-profit sectors, and we have to be an equal partner at the table. It also has to include government representatives from the Department of Labor, Justice, Housing, and Defense, and it also has to meet. We also support very strongly and encourage the continued funding of training components of the Combating Autism Act. Finally, I would just like to encourage that, as said prior to all this, the need for adult services is extensive. When you talk about a fiscal cliff, the greatest cliff that occurs in our community is that when a person turns 21 and absolutely no services are available for that person when they need. And again, we thank the committee, and I'll be happy to answer any questions when all the other speakers are over.
Thank you, Mr. Badish. Mr. Wright, did you just have one quick point?
A piece of information just came to my attention. The Senate just passed the TRICARE Amendment, restoring all military personnel ABA therapy, whether retired or in service. It's taken 5 years to do that. 5 years.
Mr. Blacksall, you are now recognized for your testimony. Thank you.
Good afternoon. I'm honored to be here to represent Safe Minds, grateful to the Chairman and to Congressman Burton for his terrific work. And I'm humbled by the opportunity to represent the community of autism families. I would like to enter into the record. We've collected testimonials in the last couple of days from over 300 autism families who wanted to attend the hearing but could not. And you can read their statements here.
Without objection, so ordered. We will include that in the record.
I wrote a book on autism. It argues that autism is a new condition. In 1935, Leo Kanner wrote this book. It's 537 pages long, not a whisper of autism in any of it. 3 years later, he saw the first child with autism, a family from Mississippi that came all the way up to visit him, and he'd never seen a child like Donald Triplett before. In 1943, he wrote his famous paper in which he argued, since 1938, there have come to our attention a number of children whose condition differs so markedly and uniquely from anything reported so far that each case merits a detailed consideration of its fascinating peculiarities. Before 1930, the rate of autism in the world and in America was effectively zero. Today, nearly 70 years after Conner's paper, reported autism rates are 1 in 88. In New Jersey, 1 in 29 boys born in 2000 were diagnosed as autistic. What's going on? Why are so many American children sick? I think we have to face reality. We need to be clear. Autism is a public health crisis of historic proportions, worse than poliomyelitis. It's devastating a generation of children and their families. We need to face that reality. Autism is a national emergency. Could we skip to slide 5? There's a summary here of historical autism surveys in America. For a long time, we had low rates in America, about 1 in 10,000. Keep flipping. There we go. Then around 1990, something new and terrible happened to a generation of children. Autism rates didn't just rise, they multiplied. This escalation covered both full syndrome autism and the broader autism spectrum, including Asperger's. Some people claim this isn't real, that we're just doing better diagnosing. That's just wrong. If you read the old literature, the old surveys, they looked for everybody, and they couldn't find people. They didn't miss 99% of the children with autism. It's not hard to find a child with autism. It's obvious when they're autistic. The notion that we're just doing better diagnosing, even in the CDC studies, they're using the same methodology. So when you see those numbers rising, that's not because the methods are changing, it's because there are more cases. In the midst of this crisis, the federal agencies responsible for the health of our children have failed in their duty. CDC's negligence has led the way. Many of us believe CDC has actively covered up evidence surrounding autism's environmental causes. NIH, meanwhile, has received the lion's share of funding, money they've wasted on status quo research and gene studies. It's absurd to focus on genetic research in this crisis. There's no such thing as a genetic epidemic. I'll skip past a couple of examples of malfeasance. I'll just say that in the financial world, the result of pressure to manipulate numbers to provide the answers that bosses want has a name. It's called securities fraud. In medicine, there are similar pressures. They're called special interest politics and even peer review. And what CDC has given us is the medical equivalent of securities fraud, all to avoid the inconvenient reality of the autism epidemic. In the face of a national emergency, government agencies, especially CDC and NIH, have performed poorly and behaved badly. We need accountable new leadership on autism at NIH and CDC. We need an advisory committee that believes in combating autism, not newly stocked with appointees who actually oppose that mission. We need a Combating Autism Act that truly combats autism. We need to stop investing in the autism gene hunt and identify what has changed in the environment that it could possibly have injured so many children. The scope and the magnitude of these changes, it's complicated, yes, but it can't be that complicated. There have to be a very small list of things that could have changed. Ultimately, we need to face and answer the question, why are so many children sick? We'll only do that hard work if agency leaders are held accountable to the American people, not powerful interests in the medical industry. So we're asking you, the members of the committee, for your help. Please, let's not make this hearing a one-time episode. Please stay on the job in the next Congress. Root out the failures, the waste, the fraud, the negligence, and the abuse in these agencies that aren't doing their job. We need CDC and NIH to do their jobs, and they're not. There's a crisis. We need your help. Thanks very much for your time.
Thank you. Thank you. Thank you. Thank you, Mr. Blaxall. Mr. McGarry, you are now recognized for your testimony.
Thank you, Mr. Chairman, for the opportunity to address this committee and to discuss the rise in autism spectrum disorders, its impact on post-secondary education, and the allocation of government resources for ASD. As we've discussed, the CDC now indicates that 1 of every 88 births in America results in a child diagnosed and living with autism spectrum disorders. As these numbers are staggering, students diagnosed with ASD are now of age where they are applying to higher education institutions across the United States in the same record numbers. It is estimated that within the next 2 years, 1 of every 100 college applicants will have an ASD diagnosis, and this is just the beginning of the wave that has been characterized as epidemic. In 1984, the Learning Differences program at Mercyhurst University has educated and assisted nearly 1,000 students with disabilities to succeed in college, earn a degree, and go on to make a difference in the world. In 2008, Mercyhurst introduced the Asperger Initiative at Mercyhurst to meet the unique needs of the growing population of college students diagnosed with Asperger syndrome and ASD. The AIM program focuses on building a foundation of self-advocacy, social skills, and sound academic progress. Thanks to an appropriations grant in 2009, we did receive $100,000 from the U.S. Department of Education, and we were able to launch the AIM program. 2 short years later, in 2011, Best Colleges Online ranked our Asperger Initiative at Mercyhurst number 3 in the nation on their list of impressive special college programs for students with autism. Mercier's President Tom Gamble emphasized that Mercier's believes that capable students, if given the environment and opportunity to succeed, will do just that. Dr. Gamble has committed Mercier's to continuing the development of the Asperger program. Very few colleges and universities across the United States offer a program of collegiate support like AIM for this cohort of students. Too few are equipped to educate college and post-secondary students diagnosed with ASD. We have found that AIM students are able to excel academically, but most have a great need for internships and job coaching. Few have ever held a part-time job or understand the nuances of the workplace. The Department of Labor and Industries Office of Vocational Rehabilitation has been helpful in providing support for our AIM students, but is limited to only supporting students or employees, and neither internships nor job coaching are covered under current OVR restrictions. Jane Tearfield Brown cautions in her book, Students with Asperger's Syndrome, A Guide for College Personnel. The 1 in 88 number of incidents cited by the CDC will begin to be realized when overeducated and under or unemployed adults with AS are brought into the welfare and social services systems. Individuals without jobs will pose a burden on their families, on insurance companies, and on federal and state social services. This is not only an unnecessary but also critically unfair to a large group of people in our society. To prevent this scenario, changes must begin now. Mercier's is dedicated to educating and preparing all of our graduates for productive careers. We've tried to develop partnerships and have with the Verizon Foundation, the PNC Bank Foundation, Conquer the Canyon, and other private donors. The next step for the AIM program is to fund and launch our internship program for our seniors and provide job coaches as needed to prepare them for the workplace. The AIM program has been cited as a model program and has implemented a majority of the innovative components of the program with limited resources and opportunities beyond the commitment of the university. It is our hope that a strong consideration is made for allocations of government resources to fund programs like the Asperger Initiative at Mercier's that assist students not only in receiving a college education, but also in helping them become productive citizens in our society. As a provider and a father, I strongly feel we need to act now before the task before us becomes insurmountable. Thank you again for your time and this opportunity.
Thank you, Mr. McGarry, for your testimony. Mr. Carley, you are now recognized for your testimony. Thank you.
Mr. Chair, I would ask for just a little bit of leeway since, having only been asked to speak Monday morning, I haven't had the same amount of editing time as many of my colleagues. Just a minute or two would be most graceful.
Well, do your best and we'll work with you.
Thank you very much. As the Executive Director of both ASTEP and GRASP, and on behalf of both my boards, I would like to thank all the members of the committee here for having me to speak. I bring two concerns, both of which shed light on a population of people on all sides of the spectrum and on all sides of the many controversies that exist in the autism Asperger world, who are simply overwhelmed. And I hope to be able to stress the negative consequences on us all when so many are enduring financial, logistical, and emotional stresses of a magnitude that might surprise you. My first concern is the more standard apprehension concerning the direction and prioritization of government funding. Currently, the emphasis is on government research, and there is good herein, as well as fairness, for there is a vastly disproportionate amount of research funding for autism when compared with infinitely less prevalent conditions. All that said, however, research is based on the future and not where our greatest need lies, which is in the present. Today, the services we collectively offer is paltry in comparison with the true need that's out there right now. The majority of our families still do not have the appropriate services, interventions, or educations available to their children, and adults on the spectrum are starved for appropriate housing, therapies, and employment opportunities. And if fiscal concerns are indeed something which we measure things by, then let's think of that adult who, if they are able, in a job employment program to become a tax-paying, productive member of society rather than existing on government support seems to me like a financial no-brainer. And for those who are not able to participate in programs like that, think of the productivity that is lost because the parents can't produce like they used to. Why we never consider the fiscal cost of not providing services is still a mystery to me. And I disagree with some of the testimony we have had here before. We are not amidst a health crisis. We're amidst a services crisis. My second concern has to do with how we implement whatever direction we take in terms of the tone or the language being used. Now, tone or language may seem like PC, self-help, feel-good spin to a lot of people, and I understand that. But it's not for someone on the spectrum who grows up having to hear words like cure, disease, defeat, and combat, words that have no medical basis given the genetic component of autism. For though we may improve dramatically, we're born with this, and we will die with this. And such negative self-imagery makes self-esteem so much harder to achieve for an individual who is at a psychological disadvantage, enough as it is. We have to remember that the majority of this population now can read what's being written about them and hear what's being said about them. And as we all grow, whether we're on the spectrum or not, we need to hear about what we can do, not what we can't do. Autism is simply more complicated than any of us want it to be. Try as we may, we cannot sloganize it, we can't dumb it down. And historically, our refusal to accept the complexities of this vast spectrum has created a competition of suffering amongst ourselves that has made the autism world and its politics one of the most emotionally unhealthy atmospheres you could ask to work in. Is this because we're all so overwhelmed, thanks to unmet service needs, to process these different lives in a more productive manner? I think the answer is yes. Now, I was lucky. When my then 4-year-old son and I were diagnosed with Asperger's in late 2000, I was at a point in my life where I had a family, I had a career. It was a weird life. I was a starving playwright by night and a minor league diplomat during the day, working in such places as Bosnia and Iraq. But there was proof that there was possibility within my son's diagnosis. Most other parents might have resorted to praying that their child could have a future. Thanks to my diagnosis and the life lived up to that day, I had the advantage of evidence-based conviction, not hope. And self-esteem was the most formulative factor in all of that. Now, granted, I am at one end of the spectrum, and I understand that to many parents I will seem like the possible and not the probable. But I also would never invalidate that the prognosis for me was once not so good, nor that my behaviors haven't dramatically changed for the better. And what is considered probable has changed immensely over the last 10 years, and that is a credit to everybody working in the autism world. Self-esteem, again, was the most predominant quality that got me to that point, because unlike other people on the spectrum who are brilliant, I don't have that kind of a brain. And lastly, it's an ethical mistake whenever we sacrifice the possible in the name of the probable. As national nonprofits, like government thus far.
One question. Is there one more point you wanted to make, or is this your conclusion?
This is the concluding paragraph.
Okay, fine. Well, take your time. I didn't mean to rush you that much, but I thought you had another whole point you were developing.
I'm good, sir. No.
Okay, thank you.
As national nonprofits, like government thus far, we too have often failed to lead. Our centrists have frequently been too hesitant, but more damaging are the militants on opposite ends of the controversies who have pandered to their members' anger, anxiety, or depression with alarmist rhetoric, misinformation, fight talk, and all this encouraging the search for a bad guy, somebody to blame, thereby pouring gasoline on the fires of the people that are looking to us for leadership, instead of helping them with messages of acceptance, respect, openness to a path that may be different from what was expected, and helping them get the services they need. I ask this administration, as well as our community, to lead and to help these constituents in such a way that will not just be acceptable to the polls or pander to any ill-conceived notion that an injustice was done or that there's something in the water. I cannot stress enough my disappointment that the conversation on vaccines is still evident. Despite the immense progress.
Mr. Crowley, at this point, I appreciate that, but in respect to each of the panelists, I've given you a significant period to go on. But please appreciate that we will take your testimony in its written form and assure that it is part of the written record. Thank you so much. Mr. Neiman, at this point in time, I recognize you for your testimony.
Thank you, Mr. Chairman, Ranking Member Cummings, and esteemed members of the committee. My name is Ari Naaman. I represent the Autistic Self-Advocacy Network, an organization run by and for autistic people. I also previously served on the Interagency Autism Coordinating Committee, and let me just say, as an autistic person and as a taxpayer, I want to thank you for giving self-advocates a seat at the table today. I'd like to begin with a story. Earlier this year, I was visiting a service provider in New York, and I happened to meet a young man my age. We'll call him Joe. And Joe is autistic, like me, but unlike me, Joe doesn't speak. He had come in with his father to try and find a job, and I had the chance to sit down with him and his dad and ask some questions. And Joe, despite not speaking, found ways to be very actively involved in that conversation. He pointed at what he was interested in, shook his head at what he wasn't. He had plenty to say, and few people had ever bothered to pay attention. No one had ever given Joe the simple support of a communication device. That technology exists. It has for years. We just don't invest in it. And I think about Joe a lot at times like this because the current autism research agenda largely ignores his needs. I'm a big believer in the old maxim, in God we trust, everyone else please bring data. So if you don't mind, I'd like to point to some of the data in the autism research agenda and see what it shows us. In 2010, NIH spent about $217 million on autism research. Of that, only 2.5% went to research on improving the quality of services. Only 1.5% went towards research on autistic adults and our needs. Now, when you compare that to the percentage of the research agenda focused on causation and biology, the attention paid to the needs of us here today is laughably small. Now, I'm not here to speak for all autistic people. That's impossible. But I am here to speak for the right of every autistic person to get the support they need to speak for themselves and not to be written off as victims or burdens. Now, some have tried to justify the lack of attention paid to services and adult issues through talk of an epidemic. I don't happen to subscribe to that theory, but if we wanted to study it and evaluate it scientifically, a very simple step we could take would be to research the prevalence of autism in the adult population. The United Kingdom, in fact, conducted that study and found a comparable rate of autism in adults as in children. We should be doing that here, and regardless of the result, we would gain valuable information on supports for autistic adults. I want to highlight 3 additional points noted at more length in my written testimony. First, I think it's very important to stress that there are really severe racial, income, and gender disparities in the autism world. As was mentioned earlier, African American children are diagnosed significantly later than Caucasian children. Department of Education data has also showed us that low-income and minority youth on the spectrum have the lowest rates of employment and higher education access in the years after they leave school. We also know that gender plays a big role. Many believe that the 4-to-1 ratio of boys to girls being diagnosed is at least partially a self-fulfilling prophecy, with girls less likely to be identified because they don't fit the stereotype. Second, I think it's important we recognize that when we talk about autism services, we're mostly talking about services with the word disability, not autism on them. So we have to talk about programs like IDEA and Medicaid, and a few words on Medicaid in particular. The vast majority of disability services are financed through Medicaid. If that program were block granted or otherwise significantly cut, those services would be devastated. I cannot emphasize this enough. Ending a robust federal commitment to Medicaid means ending any meaningful chance we have to support autistic people. Third and finally, I want to stress the importance of building a pathway to employment for my community. Our current disability service provision system actually makes it very hard for people who want to work to enter the workforce. If you're leaving school, you have to choose between going without support or committing to exit the workforce in order to qualify for SSI and Medicaid. Quite frankly, that's just bad public policy. If you want autistic people to be tax-paying citizens, and we want to be, we need a service system that emphasizes employment. The Affordable Care Act has made some progress towards those ends. Another good example of what more we could do can be found in the TEAM legislation, a bipartisan collection of bills on transition for youth with disabilities introduced by Representatives Harper and McMorris Rogers. In closing, I want to point out that historically, most disability movements have a certain life cycle, and autism is no exception. In the beginning, most public attention focuses on questions of cure and causation. But with time, both advocates and policymakers realize that the real issues relate to helping support and defend the civil rights of people today. Now, in autism, that process is still going on, but I'm confident. I'm confident because I believe this is a civil rights issue, and I believe that the United States of America can guarantee the civil rights of all of its citizens. Thank you very much. I look forward to your questions.
Thank you, Mr. Neiman, and thank you to each of the panelists. Now, in regular order, the Chair will recognize Mr. Burton from Indiana. Mr. Burton.
First of all, I want to thank you all very much for being so patient. I mean, we grilled those people for, what, about 3 hours, and you had to sit there. So I want to tell you, I'm amazed that your posteriors could survive that long. That's the first thing. The second thing I'd like to say is that Abraham Lincoln said, "Let the people know the facts, and the country will be saved." And one of the problems that we have is that I don't think there's enough information getting out to the people who are not affected. I was like that. I didn't know much about autism until my grandson became autistic, and then all of a sudden it became a cause célèbre for me, and it was fortunate that I was chairman at the time, so I had the resources at my disposal to do something about it. So I'm asked my staff, I want you to get a copy of this whole hearing, every one of you. You can get it on the internet. What's our internet website? governmentoversight.house.gov, governmentoversight.house.gov. And I would urge all of you to disseminate this whole hearing and try to get as many people as possible to look at that. Because the more people that know what's going on and understands it, the more likely we are to get some kind of positive result out of the FDA and HHS. And they get a lot of money over there. I don't know why in the world they can't allocate more money for this whole issue. And that's why it's important that you keep beating the drum. I'm retiring. This is my last year in office here. Been here 30 years, but my last year. But I want you to know, any of you that have need any of your organizations, you get a hold of me, and I'll do everything I can to help you, because this is something I feel very strongly about. Now, the other thing I want to talk about is we have what's called the Vaccine Injury Compensation Fund. It has $2.4 billion in it, and it's not being disseminated to people who have damaged children. And it's because we have a system which was supposed to be user-friendly that is not user-friendly. We have special masters that are saying, you know, we can't prove or can't make sure that this person deserves any money out of that fund. And so I think it's important that we beat the drum on that, because there's $2.4 thousand million in there. And there's a lot of money for people who really could use it. And that was put in there by the pharmaceutical companies to help people in a user-friendly way to solve these problems. I think that's about all I have to say, except I'm very sympathetic to all of you. We've had, I don't know how many hearings on this subject over the past decade, but the problems just keep getting worse and worse and worse. And we really need you not only to be the foot soldiers, but the people that are going to lead the charge to make this a cause célèbre for everybody, even those who aren't affected by autism. It will affect everybody that knows anything about autism, because these people are going to live, as we said before. You've all mentioned this to a degree. These people are going to live for some time, and they're going to be a burden not only on the families but on society. We had people come before my committee whose children they were afraid of. They would lock the doors when the kids got out of control because they were so big. People that mortgaged their homes and lost everything they had taking care of their kids. That is not widely known. And that's why it's important that you guys keep beating the drum and get the message out there, not just for your family, but for everybody in our society. Thank you, Mr. Chairman. I yield back.
Thank you, Mr. Burton, and thank you for your passionate advocacy on this issue for your tenure. And we genuinely appreciate your leadership and look forward to hoping that we can continue to carry the mantle. At this moment, let me recognize the distinguished ranking member, Mr. Cummings.
I think, you know, I want to thank all of you for shedding so much light on the subject. I think my frustration comes with regard to trying to make sure that we take your pain, as I was telling you, Mr. Wright, that has now been turned into a passion to make sure you carry out your purpose to help the folks that you want to help. And I'm sitting here trying to figure out how do we effectively and efficiently use your energy and your passion so we get something done. I was listening to you, Mr. Blaxell, and basically, if I understood you correctly, it seems as if you feel that there has been a lot of game playing. And I don't know if you used the word fraud, but you came pretty close. And, as I listen to you all and I think about how these numbers are increasing, we are marching into a very, very serious situation. And I know, Mr. Neiman, you said don't call it an epidemic or whatever you said, but this is serious stuff. You've got, and you all know, but I'm just listening to you. I'm sure you got parents who have to give a lot, and so their productivity is affected. We've got people who are struggling with this and not getting the services that I guess could make them even more productive. Am I right? Is that what you're saying, Mr. Cawley?
It is, and I do want to reinforce this is, in fact, very serious. My concern with the rhetoric of epidemic is that it, A, seems to stand in contravention to a growing amount of science exploring whether or not we are seeing a rise in incidence or a rise in diagnosis, but B, I'm concerned about the population that Congresswoman Norton mentioned earlier, many of whom are my members and Mr. Carley's members, who have often gone for decades without diagnosis or who have been misdiagnosed. The perception that autism is some recent new thing has been very damaging, in part because it's meant when we talk about autistic adults at all, which we do very rarely, we never talk about their needs. We always talk about it as something very recently on the horizon or about to be on the horizon. And we have to recognize this is a very serious situation. It's a very serious situation now, and it's a crisis not of epidemic or public health, but of unmet need and of human rights.
And that goes to my very question, and maybe you can address this, somebody. Tell me the kind of services that are lacking that you would like to see provided, again, so that we can try to figure out how we can use our dollars effectively and efficiently to not only, I think it was you, Mr. Carley, who said, yeah, we got to look at the future, we got to do our research. somebody said this, but we've got to also make sure that we deal with the now, because the people in this room, I take it, are going to go home and they're going to have to wrestle with this with love and affection 24/7. So while they are, I guess they have two situations. One, they're reaching into the future and saying, you know what, we want to understand what's happening here. We want to know the causes. We want to see if there are cures or whatever. We want that. But we also need some help right now, right now.
Exactly. And if I may,
and what help is that? I guess that's what I'm trying to get to.
It's a myriad of things. I mean, for parents of more challenged children, we're talking about ABA therapy in the home. We're talking about a variety of educational strategies. We're talking about an appropriate education and perhaps, just some aftercare if the child is significantly, challenged enough. For someone that isn't as challenged, we need much more enforcement of IDEA in the schools. The schools are still able to circumvent that. I know it's budgetary, but it's still a problem that needs to be fixed. Adults themselves, they need appropriate housing. Adults need therapeutic options. When you grow up living in the behavioral minority and you're living in a world that confuses you a lot, you need to talk to somebody about that. But most of all, especially for adults, those employment programs, putting them into being productive use. This is not a population of people that are short on brain cells. It's social deficits, it's executive functioning issues, it's hidden curriculum issues. They can be put to work. Now, if I may, though, just backtrack because, again, we've heard so much about prevalence rates and the confusion of where did these numbers come. Not once have I heard today the fact that the DSM-IV, which is what diagnoses people and constructs what the criteria is for who deserves a diagnosis, not once has anybody said here today that one of the reasons for the expanding diagnosis was the expanding criteria to what meets a diagnosis. First off, the inclusion of Asperger's syndrome in 1994 certainly opened up the book to a plethora of people, including myself, who never otherwise beforehand would have qualified for an autism spectrum disorder. But even traditional autism, the definition was changed in that book. I may get these numbers wrong, but in the old book, I believe it was 6 mandatory criteria for a diagnosis of autism. So if you got 5 but not 6, back in those days, it was mental retardation. Now, I believe it's 8 optional out of a field of 16 possible criteria. That blows those numbers off the roof.
Thank you. I see my time is up.
Mr. Cummings, there does seem to be, would you want to be recognized for a minute if Mr. Blaxell has a quick comment to be made?
Thank you, Mr. Chairman.
I'd like to
I would like to
elaborate on the service question, if possible.
Excuse me, Ari,
If you can, we're trying to extend a courtesy to allow this important question. Mr. Blaxell, if you will.
Thank you.
You did raise your hand.
I want to raise 2 points just to correct the record. First of all, the 1 in 88 numbers, one of the problems with what the CDC does is they don't break out the categories. So we don't even have the tools to inspect the claim that there's been diagnostic expansion and the inclusion of Asperger's syndrome made a difference. To the extent that there is data in the CDC numbers, Asperger's syndrome is a very small proportion of the total categorized cases, less than 10%. So the notion that we've had diagnostic expansion, that dog don't hunt as an explanation. And DSM-IV, if you actually read what the designers of DSM-IV wrote about it, they said it was supposed to be a corrective narrowing of the diagnosis. That was their intention. So I think this notion that we've got diagnostic expansion is a dangerous one. Another point I want to make, and I didn't have a chance to make it, the great unmentionables, vaccines and mercury as causation factors. If we have an environmental epidemic, which is what I think common sense will tell you we have to look at plausible candidates that could possibly explain the inflection point that we saw in 1990. And so far, the best candidates we have are mercury, and there's a lot of evidence that supports mercury as a causative factor and a damaging factor. And the vaccine issue is a tough one. There are, contrary to what CDC representative said, there have been no studies of the total health outcomes of an unvaccinated population as compared to a vaccinated population. The studies that have been done cover only one preservative and one product. We haven't looked at combinations. We haven't looked at the totality. And those studies are often done poorly. And what we hear about are the studies that CDC has done, which I would argue there's been statistical trickery. But if you actually look at the record, mercury, for example, there was one paper that was written, showed that 43 out of the 58 studies on mercury and autism, or heavy metals and autism, were positive. It's the other 15 that we hear about in the press. So the scientific record is very supportive of the environmental concerns that parents and families have. It's complicated. There's controversy, obviously, but the notion that the controversy is settled or that all the evidence weighs on one side, that's politics in science. That's not an issue of the evidence.
Thank you. Thank you, Mr. Blaxell. In regular order, I now recognize myself for 5 minutes of questioning, but Mr. Wright, this testimony today has been revealing, and in many ways what struck me has been the fact that we can have been at this issue for so long, and there's such a wide divergence just even in the scientific definition of where we are, the accurate identification. You've spent a great deal of your time, resources, and passion in this issue. Now, one of the things I was trying to explore, and I know you've been discussing, we've got this interagency autism coordinating committee that the government has, but it seems to be missing the mark if we can be so far off on this. So give me your impression of what we should be doing right.
What we need is a national strategic plan. There are many government agencies that are doing a lot of good things, but they're not necessarily together. The money is significant, but it isn't necessarily spent in as thoughtful a way as possible. There needs to be a combination of the CDC, the NIH, and the FDA as an example to actually undertake the correct research, stay with it, especially in safety research on vaccines going forward. And there needs to be some place, there should be an Assistant Secretary of Health. The ASH title has been around for a long time. Somebody has to coordinate all this activity and try to make, that's where you bring in services. The NIH doesn't do services, so they'll just tell you that. We don't do services. CDC doesn't do services. And so you've got, but yet it's done inside of Health and Human Services, but it's not coordinated. So a national plan, a national strategic plan would be what I would advocate to try to pull that together. I think that's a very important thing. It also involves continuing medical education for pediatricians. It also involves going to medical schools. There's nothing. You know, mental conditions occupy a fraction time in medical school. And then people go into practice, and what we deal with is a lot of ignorance. So you have to keep, that has to be organized. So that would be my fondest hope.
Mr. Badish, did you have a comment with respect to that?
I would just suggest, with all respect, that the IAC doesn't coordinate.
I'm sorry?
That the IAC doesn't coordinate. And that until we recognize, as Mr. Wright says, that we have to look at this as a national societal issue. And you can't have a body that's tied into, as Mr. Wright said, into a health research mode, looking at this whole element of autism. The service needs are there, the civil rights issues. When you don't have the Department of Education sitting at the table, where every single parent and every...
Or Department of Labor might be another suggestion, or even the Department of Justice.
It has to be a coordinated body. And with respect to the administration, we've talked to them, and I think they understand that now. But it has to start, in our opinion, from moving IAC, which is, as Mr. Smith knows, is a great concept, but it's in the wrong place. And it has to have a societal commitment that we're going to address this need as a lifespan issue from birth till death. And until then, we're not going to get anything. IAC, I've been the president of the Autism Society every year and a half. IAC, despite what they said, I've never heard, they've never approached us. So if they're doing a national plan, God love it, you would think they would approach the largest grassroots organizations. I assume they haven't approached most of us at this table. That's a major problem.
Mr. Blaxell, if I understood your testimony, you identified that there has been extensive research going on in something that you would suggest isn't even relevant to the discovery of what's going on. Was it genetics, or was I correct in that?
Yeah, that's correct. I mean, we've spent tens of millions, hundreds of millions on what I call the great autism gene hunt. You know, when common sense would tell you that if we've gone from 1 in 10,000 to 1 in 88, something has changed.
Who, in addition, adopts your position, and why would that issue not have been raised prior to today?
I think it comes back to the strategic planning issue. When a group of us pushed for the Combating Autism Act of 2006, one of the critical provisions of that was the idea of a strategic plan to make IAC and to make the NIH funding mechanisms accountable to the public. I spent 25 years in management consulting. I was a senior partner at one of the top management consulting firms in the world. If there's anything I can claim to be an expert in, and I hate to invoke expertise because that's often a way to keep the people out, but I'm an expert in strategic planning. And I was asked to participate in one workshop at NIH, and I can tell you that the process that we were engaged in was an interesting one. It had nothing remote.
Were you shut out with respect to your commentary, or was there?
It was just an occasion to gather a group of people for a meeting, and the leaders of the NIH did what they wanted to do in the first place anyway. It wasn't accountable in any meaningful way to they didn't. It was. You get into the details, but there was an attempt not to have a strategy. It was an attempt to defend the status quo.
My time is up, but one of the things, and Mr. Issa has clearly stated the intention of this committee to continue to look at this, and that would be you would arm us if you would help us with identifying the kind of questions that you would like to have asked if we had these same individuals from that coordinating committee sitting at this table that would help us articulate in your voices the kind of inquiry that would shake that and produce a result that would help us deal just on the front end. And I'm sympathetic to all your issues on the back end as well, but my time has run out. And so at this point in time,
I would suggest that those answers might be urgency, goals, milestones, time frames, and passion.
In that order. The Chair now recognizes Mr. Davis.
Thank you very much, Mr. Chairman, and I want to also commend all of you for your patience, for your passion, for your interest, and for your hopes, because notwithstanding the frustration that we all express, if you didn't think there was some possibility that something could happen, you wouldn't be here. And that's an indication that wherever there is life, I've been told, that there is hope. I was reminded of a poet who suggested that some people see things that are and ask why, but I dream of things that have never been and ask why not. And it seems to me that you're saying, why can't we have the services that we need? Why can't we have the kind of diagnosis that are accurate and give us the best chance and the best possibility? Why can't we even find, although we know it's difficult, we know that resources are scarce, that money is short, but we also know that priorities determine how we use whatever resources that they are. And so you're asking, really, all of those questions. I am one who believes that this fellow Sam Cooke was probably pretty accurate when he wrote the words about change coming, when he said that I was born by the river in a little tent. And just like that river, I've been running ever since. It may be a long time coming, but I know some change is going to come. I can think of illnesses and the way we've handled them in the past, and maybe there wasn't much hope. I remember living in a county where there was one physician for the whole county. Well, it took some time, but there are more than one physician in that county now. And so, quite frankly, you give me a great deal of hope. that there is possibility that when we add all of the factors together, and when the American people will have spoken, we will see some movement and we will see some possibility. Mr. Neiman, let me ask you, you mentioned the whole business of different kinds of disparities, which is something that I've been dealing with all of my life. Could you speak a little bit more and elaborate on what those disparities are and how you see them?
Absolutely. So we know that African American and Hispanic children are diagnosed later in life. It was mentioned earlier in the hearing that we see lower rates of diagnosis in the Hispanic population. And I really thank you for asking that question, Congressman, because it gives us an opportunity to call attention to the fact that we aren't doing a very good job of cultural competency in diagnosis for English language learners, for racial and ethnic minorities, for low-income communities, for women and girls, and also particularly for adults. When we look at insurance coverage and efforts to address insurance coverage needs for individuals on the autism spectrum, often the emphasis is very specifically on children, and adults are not included in state laws or federal research efforts that emphasize these needs. All of the incidence statistics you heard earlier focused on 8-year-olds. We don't look at the population beyond that. I also think we can't underestimate the role of poverty in this. And to be a disabled person is to choose essentially between accessing no supports or going on the SSI program, which places extremely draconian limits on the income you can earn and what you can save. People on SSI can't save more than $2,000 in assets. Until we address the systemic poverty that forces people with disabilities, including autistic people and our families, to be held behind economically, we're not going to be able to address the racial, income, and gender disparities in the autism world.
And all of those who have come, and please note that there are some individuals in public office who share much of the hope and much of the concern and much of the anxiety that you have expressed. And I thank you, Mr. Chairman, and yield back the balance of my time.
Thank you, Mr. Davis, and the Chair recognizes the skillful capacity with which you were able to get the great Sam Cooke into the record. The Chair now recognizes the gentleman from New Jersey, Mr. Smith.
Thank you very much, Mr. Chairman. I want to thank our panelists for their wonderful insights and incisive testimony. You know, one of the issues that Mr. Badich raises and admonishes the committee to look at the increased federal response to the needs of adults living with autism, and I think that's echoed by other panelists and by all of us. We have not done even a scintilla of what we need to be doing to address that important issue. I would like to focus on older parents, the need for support. I think they have few parallels. I've known many autistic families, and there is a burden that they carry that is so grossly underappreciated, and so many of them do it with such grace and with such dignity. Great courage, and I think we need to recognize that. But what I'm finding, and I know we all find this, that many of those parents who have older children who are autistic, and they're no longer children, they are adults, are facing a fright that they may soon pass on, what happens to their child, and even physically, the inability to deal with particularly a young man who's got strength, and they increasingly do not. I hosted Chuck Colson's daughter, who wrote a wonderful book called Dancing with Max, who goes through her whole life and what it's been like, and that's one of the concerns she expressed with us. So perhaps Mr. Wright or Mr. Badich, if you could speak to it, others as well, this idea of older parents and aging out. And secondly, Mr. Wright, if you could, speak to you laid out 5 very specific points, pillars for a national strategy. We're in the second decade, obviously, And pardon me, you know, maybe you don't like the language, but my wife has a severe immunity disease called myasthenia gravis, and a very severe case of it. When we talk about defeating and combating and curing, we mean it. And she deals with it, and she'll say it herself. And I do certainly understand where you're coming from, but we do need, I think combating is a way of rousing people to say more resources to fight it. But Mr. Wright, if you could speak to the 5 points and then talk about the older parents and the older children, young adults.
Right on the table right now, there are 2 service issues that are in front of Congress. And one of them is the ABLE Act, which is not confined to autistic children, but for disabled, and it's just the savings. And that has 240 co-sponsors in the House and can't get to the floor, but you only need 218 votes. So I would urge you to try to get that to the floor and get that passed with 240 co-sponsors. That is something that can help families, especially working on aging children when the parents are able to put some money into that account. And the second one is there is sitting out here now that there is autism insurance for home or office or wherever in 32 states, covering 75% of the population of the country. That has to be brought back here to Congress so the ERISA companies, who are exempt from that, which are the largest companies in the country and occupy roughly half the working population. We now have half the working population in the smaller companies protected, but not the larger ones. That has to be done by Congress. That has to get on the table. In past years, that was not a difficult proposition. It's an equity issue. You have a small grocery store that is local, and they have coverage, and the chain store right next door doesn't provide the coverage. So there's 2 issues here that relate, again, to families and to give them service opportunities and hopefully reduce their debt burden, and especially the ABLE, which is a planning issue, especially as people age out. Housing is an enormous issue. We're going about it on a state-by-state basis. I don't know how to bring that to the federal government at this point in time, but it's going to have to get coordinated. It's very difficult.
Yeah, thank you. I would mention one of the things with aging parents, and particularly we now have a large group of individuals, 80s, 90s, who are the primary caretaker for an adult child, 60 or 70. The portability of Medicaid is a major issue, because sometimes when that person needs a caretaker, if that's the condition, the caretaker lives in another state, the individual moves to the state and has to get put on a waiting list. It could be 5, 6 years, which makes absolutely no sense to us. The other issue is I think we have to do a better job of working with those parents and providing more options. The lack of housing for adults, and particularly in community settings, is dismal. And until we start recognizing, and again, I think Mr. Neiman said this is a civil rights issue. When housing authorities when they define their services to disabilities as having handicap ramps, they're falling a little short. So when we put more services and make those that are responsible for certain things in the communities, make those services available for people with autism, it's going to make it easier for an adult with a child.
I want to make a point about aging out and services. I think if we think about when the inflection point in the increased rate of autism was, around 1990 or thereabouts, that's about 22 years ago. And so what we're looking at, if you just say that the leading edge of the epidemic is 22 years old, those kids are just now leaving the special education system. They're well cared for in their families by and large. They're cared for in the special education system. But as they age out, we're facing a tsunami of unmet needs for services, desperate families, aging parents, and the nightmare of every parent. If late at night at the bar when you're talking about these things at get-togethers, is what happens when I die? What's going to happen to my child when I die? Because the vast majority of these children can't advocate for themselves, or when they become adults, they're going to be disabled, they're going to be dependent, they can be abused, they can be taken advantage of and not cared for, and with often tragic outcomes. And we haven't begun to see the wave of difficulties that we're going to face. If we're going to have rational policy, we need to face up to that, and it's going to be a massive problem.
Thank you, Mr. Smith. Did you have? Well, the chair will indulge you with that.
Just very briefly, you mentioned the BRIC study in your, and I invited CDC and the ATSDR to Brick Township. ATSDR ruled out that there was an environmental pathway. You mentioned that there's a blackballing. Could you elaborate on that? If not now, certainly for the record of environmental researchers by NIH.
I could certainly provide for the record. We have all sorts of private conversations with scientists. Safe Minds funds science. We wish we had the resources of Autism Speaks. We wish Autism Speaks, and I know Bob is an advocate of environmental research, but we'd love to see more from Autism Speaks. We'd love to see more from NIH. We do work a modest amount, and so we're in contact with scientists. And the private conversations you have with scientists is that there are third rails. There are politically incorrect issues. There are career consequences for doing a certain kind of study, and there have been ritual punishments of certain scientists out there. Some very public, some more private, and there are innumerable. There are many examples of those. And when the scientists say, "Oh, we should let the scientists take care of that," no. It's not a self-regulating process, because, in fact, the leaders of NIH enforce the orthodoxy of the scientific establishment, and if you take on third-rail questions, those are suppressed. We have many examples of those. I could provide some more.
Thank you, Mr. Smith. The chair now recognizes the gentleman from Pennsylvania, Mr. Kelly.
Thank the chair. Mr. Davis made a good point when he talked about the Sam Cooke song about change is going to come, although in most of our lives there's an old adage that change usually occurs at a time of tragedy or crisis, and I think we were far past both those right now. So I want to redirect, though, a little bit. I got to tell you, Mr. McGarry is here from Mercyhurst. Mercyhurst recognized this a long time ago. I'm going to say mid-'80s, right? But then all of a sudden in 2009, you come out with the AIM program, which is the Asperger's Initiative at Mercyhurst. Would you share a little bit with us what you have been able to do? And I know you've spoken throughout Pennsylvania. You've also presented internationally what Mercyhurst is doing and some of the innovation that you've brought in. And again, if you would, just tell us how you share some of that information, how you're able to disseminate to other people, because I think there is, once we become aware, we can usually fix things. The more awareness, the better it is, and we had a chance to visit a little bit today. I admire what you have done, just not only in your academic life, but in your personal life. I know you're a person of passion. If you could share a little bit with the people here today with what Mercyhurst is doing in the AIM program.
Two parts of the question. What are we doing to disseminate information? Mercyhurst participated in May in Pennsylvania. We had the opportunity to have the first inaugural conference on autism in the higher education setting. And Mercyhurst and 5 or 6 other institutions presented there on some of what we're trying to do, and 32 different colleges and universities were represented in the audience of that conference to learn what they could do to start implementing some of the programming and things that we're offering. What we're offering at Mercyhurst is not rocket science. It's not a brand new treatment option. Some folks have talked about applied behavioral analysis, and we have collaborated with our program at Mercyhurst and ABA. But we're doing a lot of tracking and looking at the students and saying, we've identified 4 main domains that we feel are very essential for our students in the academic setting as well as vocational. And they are academic social progress, independence, social, and emotional. So we try to track those 4 things specifically, because what we're finding is if our students are lacking or having difficulty on 2 of those domains, the probability that they're going to be successful in the higher education setting and or a vocational setting drastically decreases. So we're going to continue to kind of work on that. Another thing that we are doing is a peer mentoring program. And what we found is many of the students in our program have been in mentoring partnerships, but they've never been the mentor. So we've just recently implemented our peer mentoring program where our students do meet with peer mentors at the university, but they also are going to be going down to social service agencies within Erie that have other folks that have severe disabilities and are going in as a mentor to them to say, I have accomplished something, I am a college student, people said I would never be here, and I am. And I want to help you and mentor you in what obstacles you need to face and get you through those obstacles as well. So that's some of the things we're doing.
Yeah, and as you and I talked today, we talked about employment opportunities and the idea that these are folks that can live a very productive life. They can be a big part of what it is we do as a country. And I think it's the awareness, and I really appreciate your coming here today and what you've done with your life. The more we become aware of it, the more we understand how to handle it, the more we can adapt and bring these people in with us and understand there is a light at the end of the tunnel. Now, we talked to Bill Gates. But, you want to talk about somebody who could be successful that has an autism disorder, but if you can, the 24% are actually employed, right? There's a lot of adults that can't get work. Just a little bit of that impact and what we could do to change that, because I think there is a great opportunity that these people have a meaningful life, something that they feel good about, that they get up in the morning and they can't wait to contribute.
Absolutely. Yeah, I think our vocational and our internship, unfortunately, we have a stigma, and we're working with students that have autism and are Asperger. Some of the vocational opportunities that are presented to Mercyhurst are far beyond the skills and the caliber of what our students can achieve. And so we need to have a strong awareness that, as some other panelists have said, autism is not necessarily an intellectual issue. If we can train and work on some of the social skills and the executive functioning, they can far succeed expectations and do some jobs much better than the rest of us can. Yeah. And we just need to train society to understand that and give these students those specific skills to accomplish that.
Amen. If I could, Mr. Chairman, would you share the conversation we had when we talked about the one student and the professor was outlining or giving them an assignment? I thought that was absolutely phenomenal, because what we see, sometimes we don't get it. You can't tell books by its cover. Share that, because I thought that was really uplifting.
Good. I had in the AIM program, we send a letter to every single faculty member stating that this student in your class is being supported by the Asperger Initiative, and if you or that student need resources, we are available. The faculty member contacted me on the second or third day of class and said, Brad, this student, I explained an assignment that was worth 60% of the grade of my course. And the student looked at me, and I really am not sure if he understood a word of what I was saying. And so can you work with him and help me work with him? That assignment was supposed to take 10 weeks. That student, the following Tuesday, turned that assignment in, and that professor said it was the most incredible piece of student graphic art that he had seen in 25 years. So we know that there's a misrepresentation from what we think is being heard and what is being processed in the caliber of students that we're working with.
Well, thank you for being here, and thank you for dedicating your life to making sure these people do have a life. Thanks so much. Now I yield back, Mr. Chairman.
Thank you, Mr. Kelly. As promised, this was a long and well worthwhile hearing. We learned a great many things that both we and the public were not aware of. We didn't have an opportunity to hear from witnesses who had genetic links that they could see in their own families. We certainly did not hear from the witnesses who are women who recognize in their own lives that the under-evaluation because of perhaps differences in behavior between men and women lead there to be a discrepancy in recognition and a discrepancy in perceived challenge to women versus men. We certainly learned that the State of Utah has found a way to identify differently or better or more than other states. We certainly learned that, in fact, a passive discovery system is not going to get us or any other country in the world to an accurate number or to seek out people we could help and help early. This and more will be things that this committee will continue working on as part of the legacy of my predecessor, Mr. Dan Burton, for many years. There is nothing we heard today that is off limits for us to continue to explore. This committee stands ready to take your additional comments and questions as promised. There's a C-SPAN audience. We may perhaps get additional letters. We will try to include those in the record whenever possible. Lastly, I don't believe we covered every interest group either with our witnesses or here today. So because there are so many organizations involved that want to be heard, I would only ask all of you, when you work with other organizations or groups of individuals, that you explain to them that this committee will have a permanent staffing, at least as long as I'm chair, to try to continue to consolidate information and to get government to do its job more effectively, more efficiently, and if at all possible, find additional funds to continue dealing with all aspects of this disease. And with that, this committee stands adjourned.
Hi, Jake. How are you? Nice to meet you. It's so encouraging. It's good to meet you. At the restaurant. Do you know the restaurant is?
Good to see you. Yeah. Are you? How long is it? Good to see you. So if I let me find Tracy. You have a certain number. Yeah, just give me a grant. Okay, that sounds great. Okay, so good to see you. Thanks.
I'll get the safety.
One of the witnesses on this last panel, the co-founder of Autism Speaks, Bob Wright, has written an editorial in the Huffington Post today where he calls for a commitment to diagnosing children with autism at no later than 18 months of age. Today, the average age of diagnosis is 5 years old.